Juan, since we're right on the hour, do you want to go ahead and start our introductions?
Sure will. Thanks, Dr. Lovelace. And I want to tell everyone good afternoon and welcome to the Multi-Jurisdictional Contractor Advisory Committee meeting regarding facet, joint, and medial nerve branch procedures. Thank you so much for joining us today. Just a few housekeeping details. Only the contractor medical directors and panelists have speaking capabilities on this webinar. All others will be in a listen-only mode. Jurisdictional CAC members are asked to submit comments and voting and writing directly to their respective MACs. Those in listen-only mode may submit questions through the questions window in your GoToWebinar control panel. So if you click on the triangle in front of the word questions, looking at your GoToWebinar control panel, the window will expand, allowing you to type in any questions or comments that you have. Also, if you'd like a copy of the questions that are going to be asked during today's webinar, you may download the handout that's available. So again, if you're looking at your GoToWebinar control panel, click on the triangle in front of the window that says handouts. The window will expand, allowing you to download the handout that's available to you. Today's meeting is being recorded, and audio, transcript, and voting will be available on the MAC's websites after the meeting. So with that said, I will go ahead and turn it over.
Thank you, Juan. And I want to welcome everybody and thank you for taking time out of your busy schedules to join us today. I'm Meredith Lovelace. I'm one of the medical directors with CGS administrators, and I'm joined by the contract medical directors from all of the MACs. So we'll go to the next slide with everyone's name. And on behalf of all of us, I welcome you to this meeting. And if we can just go to the next, there we go. Today's meeting is an evidentiary review meeting. So part of the LCD modernization as a result of 21st Century Cures Act is a call for local coverage determinations to be based on robust evidence review. The purpose of today's meeting is for our expert panel to serve in an advisory capacity to review the quality of evidence used in the development of an LCD. The CAC is advisory in nature, and the final decision on all issues rests with the MAC. While our experts represent vast clinical experience, since the process demands a focus on the evidence, we will ask our panelists to only share evidence-based feedback. For those who have participated in the CAC process prior to 21st Century, an LCD was presented and then comments shared. In the new process, we seek input prior to the development of the LCD, and that's what today's meeting represents. I'm confident you'll find today's panelists as leaders in the field and world experts on the topic of Facet. I also understand there are many experts that are not on our panel today, and we have CAC members from across the country that have joined us on this call. We actually have several hundred jurisdictional CAC members with us today on the call, and we very much value your input and feedback and assure you that you are part of this process. For our jurisdictional CAC members, we're going to ask if you can please submit your votes and comments in writing to your local MACs, and we'll ask that you complete a conflict of interest form for that process as well. If you can, and the purpose of doing this after the meeting is if you have additional comments to share after the discussions in areas you think we need more information about. Once the draft policy is developed and released, our jurisdictional CAC members and for anyone else involved, we're going to ask that you submit comments, and there'll be an opportunity to present at the jurisdictional open meetings as well. We will be looking at the feedback from these comments as well as from the open meeting, and that will play an important part in the consideration for the final policy development. I now want to welcome and thank our panelists for their time and willingness to share their expertise. This panel was nominated by their peers and respective societies. They have a broad representation in terms of geography, practice setting, background, and medical specialty, and their introductions are just a brief overview of their accomplishments. In alphabetical order, I want to welcome Dr. Barnhill. He is clinical instructor and president of Premier Pain Management in Iowa, credentialed in pain management through the American Academy of Pain Management, and a graduate of the U.S. Army Texas Wesleyan University program in nurse anesthesiology with a doctoral degree in nursing education. He serves as adjunct faculty with the University of South Florida, simulation-based academic fellowship in advanced pain management. Dr. Stephen Cohen is professor of anesthesiology and critical care medicine, as well as physical medicine and rehabilitation at the Johns Hopkins School of Medicine and Uniformed Service University of the Health Sciences. He is director of Blossom Pain Treatment Center, Medical Education and Quality Assurance for Pain Management Division of Johns Hopkins, and director of pain research at Walter Reed National Military Medical Center. He has over 250 peer-reviewed articles, reviews, book chapters, awards, and has led the way for several novel treatments. He is the editor of peer-reviewed journal Pain, on the editorial board of many other pain journals, and a member of multiple societies, as well as a retired colonel in the U.S. Army and member of the U.S. Army Medical Advisory Board. Dr. Michael Creamer is board certified by the American Board of Physical Medicine and Rehabilitation with subspecialty certification in spinal cord injury medicine and pain management. He completed his residency in PM&R at Northwestern University and has been recognized in Orlando Magazine as a top doctor since 2002. He is clinical professor for Florida State University in the Department of Geriatrics and has served on the Board of Trustees for the American Osteopathic College of Rehabilitation Medicine and is medical director of the Muscular Dystrophy Association. Dr. Hurst is director of Interventional Neuroradiology, chief of Interventional Spine Service, vice chair of Interventional Radiology Quality and Safety, and associate department quality chair. He has over 450 papers, book chapters, and multiple edited books in the peer-reviewed literature and extensive experience in minimally invasive spine surgery. He is founding editor of the Journal of Neurointerventional Surgery and past president for both the American Society of Spine Radiology, Society of Neurointerventional Surgery, and on the board of ASIPP and American Society of Neuroradiology. He is chair of the Committee for Academicians of the American College of Radiology. Dr. Kennedy is professor and chair of physical medicine and rehabilitation at Vanderbilt University Medical Center. His practice focuses on non-operative and interventional spine. After residency in PNMR, he completed spine and sports fellowship, and his research is focused on the safety and efficacy of interventional spine procedures, and he has pioneered safe injection techniques. He is the recipient of numerous research grants and has published over 90 peer-reviewed journal articles and over 50 public abstracts and book chapters. Dr. Manna Conti is an interventional pain physician practicing in Paducah, Kentucky for the past 40 years. He is board certified in pain medicine and anesthesiology by the American Board of Anesthesiology, American Board of Interventional Pain Physician, and American Board of Pain Medicine. He has an extensive background with extensive publication in the area of pain management related to facet joints and has quite a few manuscripts in the diagnostic accuracy, factors that influence the diagnosis, and therapeutic options of facet treatment. He is the primary author of comprehensive evidence-based guidelines for facet joint intervention and the management of chronic spinal pain that is currently being released by the ASIPP, and so we'll be seeing that published soon. Dr. Tim Mouse works with the Mayo Multidisciplinary Spine Center. Dr. Mouse founded an interventional pain practice 20 years ago, which has been his primary practice focus. He is the founding co-chair of the Mayo Interventional Spine Group, responsible for all interventional spine pain procedures at Mayo Rochester and the Mayo Clinic Health System. He has been the co-investigator in an NIH-funded Mayo laboratory seeking novel analgesic strategies. He's the immediate past president on the Spine Intervention Society and sits on its board of directors. Dr. Schwachman specializes in pain medicine and pain medicine anesthesiology in Covina, California, with over 50 years of clinical experience. After his residency in anesthesiology, he also obtained a JD degree. He holds licensures in pharmacology, medicine, and law, and is a diplomat of the American Board of Anesthesiology and American Board of Pain Medicine. He has multiple memberships in pain societies, including American Society of Anesthesiologists, American Academy of Pain Medicine, and International Spinal Intervention Society. He has worked as both an attorney and physician and has contributed to the literature in both fields. Dr. Sinopoulos is the director of the Arnold Warfield Pain Management Center, co-director of the Spine Center, and an anesthesiologist in the Department of Anesthesia, Critical Care, and Pain Medicine at Beth Israel Deaconess Medical Center. He is also assistant professor of anesthesia at Harvard Medical School. His research in the area of interventional pain management focus has been on the outcomes of patients receiving percutaneous decompression and radiofrequency lesioning. In addition, most of his current work is on improving the outcomes of patients undergoing spinal cord stimulation for pain by studying complications and developing strategies for potential mitigation. As division director, he is focused on building a research infrastructure to encourage junior attendings and residents and fellows to pursue research. And finally, Dr. Tracy was appointed to serve on the Medicare Carrier Advisory Committee, First Coast Service, representing Florida Society of Interventional Pain Physicians in 2007. Since that time, she has been involved in the evolution of Medicare's local coverage determination for physicians in the state of Florida, U.S. territories, and has engaged in many of the challenges in creation of policy to maintain access to care while preserving the beneficiary fund. She currently serves on the ASIPP Board of Directors, the Florida Society of Interventional Pain Physicians Board of Directors, and is chairman of Board of Trustees for HCA Oak Hills Hospital and Residency Program. I want to welcome our esteemed panel and thank you again for your contributions. I also want to point out that at the final phase of our meeting during the discussion, there will be an opportunity for questions. Questions can be entered directly into the GoToWebinar format, and so we'll be able to see those questions or comments coming from our jurisdictional CAC members and our attendees. I do ask that everybody attending the call keep their phone on mute so we don't have any background noise, and to help us all be able to hear our panelists clearly. This slide shows the voting process. Voting will be done on a scale of 1 to 5, with 1 being low confidence in the literature and 5 being the highest confidence. A score of 2.5 is considered intermediate confidence that there is robust clinical literature to support the question. Next slide. Finally, today's questions are also available in the PowerPoint that's attached to today's meeting. I am going to now turn today's meeting over to Mark Durham of National Government Service. Mark's background is in PM&R and spinal cord injury, and he'll be moderating the question section. After each panelist answers the question, we'll have a discussion, and the panelists will be voting. They'll either vote on the call or after the call. Voting results will be posted to the MAC's website with the transcript and audio after the meeting. This may take several weeks before it's posted. Our jurisdictional CAC members will turn their voting in directly to their MACs. All of our panelists have completed conflict of interest forms, and we will ask them to share pertinent conflict of interest the first time they speak. We ask our panelists to read the question aloud in case anyone is having any technical difficulty seeing the questions, and we will try to adhere to the timeline in the agenda. Our panelists are also asked to submit written comments after the meeting. With no further ado, I'm going to turn this over to Mark.
Well, thank you very much, Meredith. I appreciate that. My name is Mark Durden, and we're breaking this down into 3 sections. The first section of questions is going to be regarding procedure efficacy. Second section will be regarding patient selection. And last, it'll be more procedurally related type of questions. And so what we'll do now is start with section 1, question 1. And in this section, I would like the panelists to place particular emphasis in their answers regarding, and it'll say in the questions, but the diagnostic versus therapeutic types of injections that are given, and to consider the location, be it cervical, thoracic, or lumbar spine, injections. So it's because lumbar spine seems to be more, is deemed to be in the literature seem to be a little more effective, and then but thoracic is less, and et cetera. So if the panelists could go in that direction, I would appreciate it. I'll turn the time now over to Dr. Barnhill for question number 1.
Hello, everyone. Can you hear me? If someone could respond.
Yes. We can hear you.
Okay. Thank you for having me. Question number 1 is, the question is, what is your level of confidence? There's robust clinical literature to support the use of diagnostic facet joint injections. Do you want me to give my score now or wait till I present the evidence?
You can give your score.
Okay. I scored a 3 for intermediate, and the reason is there's limited support for facet intra-articular injection, but here's the research that I found. According to Cohen and others in 2019 from the Consensus Practice Guidelines, the multi-specialty international working group found that actual lumbar joint injection was less predictive for a response to radiofrequency ablation than the medial branch block, and identified the evidence as grade B with a low level of certainty. These results were based on a review of 5 studies. Those were Berkmeyer, Cohen 2015, Cohen 2018, Van Zundert, and Bogduke 2013. This grading is based on the modified U.S. Preventive Service Task Force criteria, once again by Cohen, presented that in 2020. In Europe, the Greater Manchester Combined Authority in 2018 failed to commission intra-articular facet injections, instead recommended medial branch nerve blocks. The Spinal Intervention Society, former ISIS, recommended that medial branch blocks replace intra-articular injections as a diagnostic indicator. Now, reasons for less predictive response to lumbar intra-articular injections were related to the high technical failure rate, difficulty in standardizing injectate volumes for testing, and the potential to produce more harm, example, joint capsule rupture. In the mid and lower thoracic region, Adeluri in 2012 evaluated 2 prospective studies and concluded that there was good evidence to support facet intra-articular injections as an accurate diagnostic application. However, the North American Spine Society in 2016 listed the diagnostic intra-articular joint injections as a non-validated procedure for diagnosing Z-joint pain. Their rationale was that intra-articular injections block the articular surfaces and the interior joint capsule. One exception or case of diagnostic intra-articular injection would be pain potentially derived from the occipital-atlanto and atlanto-axial joints, which do not have medial branch nerves. If the intra-articular route is used, they also recommended dual blocks to the high false positive rate. In 2016, a review by Manna Conti and others looked at the US and Australian data on patients with whiplash or chronic neck pain. They excluded disc herniation or radicular pain, and they found that 11 diagnostic accuracy studies to consider facet intra-articular injections as a level 2 evidence determination. Finally, Cohen stated nicely that the accuracy of the prognostic intervention depends on the accuracy of the diagnosis, including identification of the anatomic structure responsible for the pain and the correlation between the prognostic injection and treatment effect, which in turn is contingent on the efficacy of the procedure. Conclusion.
Thank you very much. Is there any panelists that would like to opine?
Yes, this is Dr. Manna Conti. Can I go ahead?
Yes, sir.
Okay. This is Dr. Manna Conti. Thank you again for inviting me here. I have no conflicts. Dr. Barnhill did a good job about describing facet joint intra-articular injections, but for diagnostic purposes, that is not what we are talking about. This is a very important question, of course, but entire foundation for facet joint interventions depends on appropriate diagnosis, which may not be made without diagnostic facet joint injections. Physical examination and clinical assessment are strongly recommended. However, this can only lead towards potential diagnosis, but not actual diagnosis. The imaging is not diagnostic. It is a universally accepted fact that intra-articular injections are not recommended for diagnostic purposes. Medial branch blocks or facet joint nerve blocks are the choice. There is high level of confidence with robust clinical literature for the same. Our recent analysis of the evidence for guidelines showed that there were a total of 19 diagnostic accuracy studies, with 10 in the lumbar spine, 10 in the cervical spine, and 3 in the thoracic spine. Further, utilizing 80% criterion standard with controlled comparative local anesthetic blocks with concordant pain relief, the evidence is level 1 to 2 for lumbar spine and 2 for cervical and thoracic spine. The prevalence rates and false positives ranged from 27% to 40% and 27% to 47% in the lumbar spine, 29% to 60% and 27% to 63% in the cervical spine, and 34% to 48% and 42% to 58% in the thoracic spine. So all in all, medial branch blocks are very valid, and they have been validated in numerous studies. We picked up 19 studies met inclusion criteria. I think evidence is very strong here. I would say the level of evidence is 4 on a scale of 1 to 5. Thank you.
May I speak?
Yes.
I think this question is kind of confusing because all the other questions in this questionnaire relate to the intra-articular injection, separating it from the median branch. And in this first question, we just used the statement diagnostic facet joint injection. So Dr. Barnhill addressed, intra-articular versus median branch injections, and Dr. Manchin addressed the value of median branch blocks. So I would have to say this question is confusing, and I would agree with Dr. Manchin and state a score of 5 for diagnostic facet injections. Thank you.
This is Dr. Durden, and would your opinion change if the question was read intra-articular injections as opposed to just facet joint injections, meaning that that the intra-articular is being seen as different as the medial branch block?
Yeah, yes, I would. And in that same section, number 3 does ask the question in that manner.
So did it change your answer?
So you're asking me if that said intra-articular injections, what would I assign?
Yes.
I would assign a 3.
Thank you.
This is Keith Barnhill again. I was interpreting that question as strictly intra-articular injection.
This is Dr. Moss. A quick comment. I think the evidence is clear that intra-articular injections do not have substantial or validated diagnostic accuracy, whereas the robust body of literature supporting medial branch blocks. One item that has not been mentioned, which denigrates intra-articular injections as a diagnostic procedure, is that the facet joint capsule is known to be fenestrated, and there can be leakage of administered local anesthetic from the intra-articular space into the adjacent foramen. So it may not be, does not even have face validity. Thank you.
Thank you, Dr. Moss. I appreciate that.
May I speak? Dr. Cohen, are you trying to speak? Yeah, we can't hear you, Dr. Cohen, or at least I can't.
Nor I.
Yeah, we can't hear you, Dr. Cohen. But one thing I did want to say, in the body of literature of the 20 articles, I didn't write them down at this moment, but 2 or 3 of them said they found the intra-articular injection to be helpful in the younger population with segmental joint effusion or inflammation. Thank you.
Thank you, Dr. Tracy. So is there any other, and I don't know if Dr. Cohen has been able to get on? If not, what I will do is I will go to question 2, section 1, and we will turn the time over. Oh, actually, it's Dr. Cohen. So let's see if we can get Dr. Cohen on the phone.
But while you're working at doing that, this is Dr. Hirsch. Could you tell us what the final question you would like us to answer is, whether it's medial branch block or facet joint injection, just how you want the final answer to read, the final answer to be?
Yes. So thank you. We want it to read intra-articular facet joint injections.
Can anyone hear me yet?
Yes, now you're on, sir.
Yes.
Okay, so this is actually covered really, really well, in those guidelines. So medial branches, so it's not possible to actually block the medial branch without blocking the dorsal ramus or the lateral branches, because even a tiny volume, half cc, spreads into an area of about 6 square centimeters. So it's not possible. And those other branches, the intermediate branch, the lateral branch, they innervate paraspinal muscles. So you can't just block the medial branch. And as Kaplan showed, there's between 10 and 15% of people who have innervation to the facet joints that are nerves that are not from medial branches, so non-medial branch nerves. So there's always going to be false positive and false negative rates with medial branch blocks. Intra-articular injections have been used to diagnose knee pain or hip pain very, very infrequently, because the American College of Rheumatology guidelines don't depend on this. There's 3 different ways. And so that has, people have said that that's self-evident, right? If you numb a joint and your pain goes away, that's the source of the joint. The problem with intra-articular injections, and you could see this from our FACT study and I think the Lynch study, is there's a really, really, really high technical failure rate with intra-articular injections. So intra-articular injections have the theoretical potential to be diagnostic. Medial branch blocks, we're using them really as predictive or prognostic tests. Predictive would be the right word. Prognostic tests to see if doing a radiofrequency ablation on those same nerves will alleviate pain. It's impossible to come up with sensitivity, specificity, or any other accuracy tests because there's no other reference standard.
And would you like to go ahead and continue on with the second question as well?
Sure.
Thank you.
Let me see over here, the second. Can you,
I got it.
What is your level of confidence? Can you read the question?
Certainly. What is your level of confidence? Is there robust clinical literature to support the use of therapeutic facet joint injections to relieve pain and improve functioning?
So let's start with intra-articular. So I'm sure that I will make a lot of enemies here. So we're not talking about radiofrequency ablation. We're talking about injections, correct?
That is correct. And I appreciate you taking on the IA facet joint question.
Okay. Yeah, for some reason I thought that I had the 1 or 2 blocks or the 50% or higher relief, but I'll go over here again. So there are several randomized trials that have looked at intra-articular facet injections. So you have two that were published in the New England Journal of Medicine, one by Cassette, one by Les Barnsley, both very, very clearly negative. And these patients were selected well because they had diagnostic tests. There were several others, Lilly, a study that didn't pre-select patients, really kind of negative, and he used HCCs. There's our FAC study, which was published in anesthesiology, and there's actually DJ Kennedy has a great study. All of them show that intra-articular steroids don't work. And as I said, there's a very, very high failure rate to these. So there's not a lot of evidence saying that intra-articular steroid injections work. Now I'll go over medial branch blocks, and I apologize in advance because I see Josh Hirsch, hi Josh, and Dr. Manna Conti, and they were on the ACIP guidelines. So medial branches this is not really medial branch neuritis. Technically, that can possibly happen from a nerve being entrapped beneath the mammalloaccessory ligament, but we're not talking about a mononeuritis over here. We're talking about facet joint pain. And nobody uses, genicular nerve blocks, femoral nerve blocks to treat knee arthritis. We don't use obturator nerve blocks to treat hip arthritis. We're not using, ankle blocks or sciatic femoral nerve blocks as a long-term treatment for ankle arthritis. Nobody is using that. So the procedure as medial branch blocks as a therapeutic procedure, it lacks any internal validity. Now, there are studies by Dr. Manna Conti's group, that show long-term benefit. But let me say something here about this. If medial branch blocks gave relief to everybody, right, or to 50 or 60 or 70%, there would be no discussion on radiofrequency ablation. We wouldn't need it because that would be higher than the success rate for radiofrequency ablation. And first of all, local anesthetic injections of any nerve never gives long-term pain relief. Otherwise, everybody who got a labor epidural would be paralyzed. They wouldn't be able to walk. Everybody who got a regional anesthesia block would have the same issue. So if medial branch blocks, which are used to select patients for radiofrequency ablation studies, if medial branch blocks provided long-term relief, we wouldn't be able to enroll anyone in studies because they wouldn't have pain. But that's not true. There's one study by NATH that actually showed, more than 15% of people had relief and they didn't enroll in the study, but it didn't say how long that relief is. But all the other studies that show, good flow charts like Van Cleef, Van Tilburg, Van Wyck, Cohen study, all of these studies, the reason that people enrolled in radiofrequency versus sham radiofrequency or something else is because they did not get long relief from medial branch blocks. And the FAC study is probably the best at this. And this showed really that about 11% of people got pain relief at 1 month. And that was a double-blind study.
Because of time, what I'd like to do is, and Dr. Cohen, I appreciate that, but we can build on this with Dr. Kramer's comment and answer to question number 3. So, Mike, could you take that?
Thanks, Mark. I appreciate it. I think some of these issues probably have already been addressed by our prior discussion, but question 3, does the clinical literature support the use of therapeutic intra-articular facet joint injections as robustly as medial branch blocks or medial branch facet joint injections? So several of the questions we've already mentioned, Dr. Manna Conti's review and the systemic review of best evidence synthesis of effectiveness of the therapeutic facet joint interventions in managing chronic spinal pain. Article indicates that for intra-articular injections, the evidence was level 3 evidence for lumbar and cervical intra-articular injections. No trials available for thoracic intra-articular injection therapy. The FAC study Dr. Cohen alluded to concluded that facet blocks are not therapeutic, but may provide a prognostic value before radiofrequency ablation. Dr. Manna presented in the Postgraduate Medicine Journal. That was on cervical zygapophyseal facet joint pain effectiveness of interventional management strategies. And he indicated in that article level 2 evidence for facet joint nerve blocks, level 3 evidence for cervical intra-articular injections. Dr. David Kennedy reported in the Journal of Pain Medicine in 2019 a comparison of intra-articular steroids versus saline for treatment of lumbar zygapophyseal joint pain. This was a prospective randomized double-blind placebo-controlled trial. His conclusion was intra-articular steroids were not effective at reducing the need for or time for radiofrequency ablation for zygapophyseal joint pain. Similar report, same author in American Journal of PM&R, October 2018, same findings were reported. There was a report, Dr. Dong Kwok in the Journal of Experimental and Therapeutic Medicine published in November 2019, the outcome of intra-articular lumbar facet joint injections. According to the severity of facet joint arthritis, their conclusion was intra-articular lumbar facet joint injections were effective, but the study was limited due to its retrospective design, small sample size, and lack of evaluation of long-term effects. There was another study, anesthesia and analgesics in July 2013, Stephen Lakemeyer, randomized controlled double-blind study comparing intra-articular lumbar facet joint injections with RFA, found similar outcomes at 6 months in pain relief and functional improvement. And then there was an article, Journal of Orthopedics, World Journal of Orthopedics, May 2016, Dr. Manna Conti, indicating the level 2 evidence for facet joint nerve blocks for long-term improvement, level 3 evidence for intra-articular facet joint injections for short-term improvement. And then Dr. Cohen's study that had been already mentioned, regional anesthesia, February 2020. Dr. Cohen recommended against the routine use of therapeutic facet injections, and intra-articular facet joint injection studies reviewed demonstrate a lack of evidence for intra-articular facet joint injections. And obviously in that article, we've already discussed some of the unique issues for intra-articular injections and steroid use. So again, given that finding, given this question of being robust, I graded a score of 2 as regarding answering that question.
Thank you, Dr. Kramer. Any Dr. Cohen, because I kind of cut you off on question 2, I'd like to give you an opportunity to respond to 3 and 2 as well, if you'd like.
Yes, this is Dr. Manchi. Can I speak?
Yes, sir.
Okay, I just want to clarify a few issues here, what has been going on, what has been talked about. We all know that there is L5 dorsal ramus and medial branches are not the sole supply. That's why we call them facet joint nerves. That is a more appropriate term. Here, Dr. Cohen is talking about an acute pain model. That is what happens in labor. Chronic pain patients are different from acute pain. If you take that, in 1901, epidural injection started. The first injection for pain was just with cocaine. The patient's relief lasted several weeks, several months. Evans, Syriacs, all these people, they were using just the local anesthetic blocks, treating the patients. Steroids were not used until 1952. So for 51 years, it was only the local anesthetic. Then it started with it. The issue here is main phenomenon is acute pain and chronic pain. Chronic pain is a complex biopsychosocial phenomenon, whereas acute pain is different. We all know that. It is a unidimensional, this is a multidimensional. So response rate is significantly different. Local anesthetics do show relief lasting for several weeks and months. We have performed multiple studies, both in epidural, facet joints, and showing an average relief of 13 to 16 weeks. even without steroids. When you use the steroids, it is slightly better, not that much. The local anesthetics and the duration of relief in chronic pain is different. It is based on alteration of multiple pathophysiological mechanisms, including noxious peripheral stimulation, the sensitization of pain pathways, and excess release of neurotransmitters. In fact, the model we are using is based on an acute pain model. That is how, when we go for the concordant pain relief or duration of the action of the local anesthetic, Bogdoc started this phenomenon. They said it is positive if short-acting local anesthetic is less than 7 hours, less than, not more than, and long-acting less than 24 hours. But that is not what we see in our chronic pain practices. And he also said it is 100% pain relief. We don't follow that. If you looked at the relief, we have studied this on multiple occasions. Our patients show that relief is much longer, 6 days or so after the first block, that is 80%, and almost 3 to 4 weeks with the second block. 6 days with the first block and 3 to 4 weeks and 4 to 8 weeks with the second block. So this is all different theories. I'm running out of my time, so I will stop there. Thank you.
Thank you, sir. In the interest of time and to stay with the schedule, I would like to move to question number 4 and turn the time over to Dr. Hirsch.
Hi, I'm Josh Hirsch. I have no conflict of interest in terms of doing facet joint interventional consulting. I did report that I do consult with Medtronic, but nothing to do with facet joint interventions. Actually, this question is a little updated, but I think works very well. Does the clinical literature support the safety of repeat facet joint injections beyond 3 injections per year? Please answer for both intra-articular injections and I believe that should say medial branch blocks. And while one of my good friends reported that he thought he was going to make enemies, I want to say that as a designated subject matter expert, I don't view my job as making enemies or friends, but to dispassionately report the evidence. I'm here with an open mind. Bearing that in mind, I think if we're talking about safety, it's fair to state that pre-Zoom, pre this conference, I think most people believe intra-articular injections and medial branch blocks are really pretty safe. Again, that's a pre-Zoom bias. I'll look forward to hearing the other answers. The original framing of the question had to do with steroids, and I think with COVID-19, we're actually seeing some change in practice with what I would term steroid distancing being practiced by some interventionalists. I mean, there's been many papers that have reviewed complications of both intra-articular injections and medial branch blocks. I would say in preparation for this call, I've extensively reviewed the safety of single and repeat facet injections with steroids beyond 3 injections per year. Again, I think the differentiation that was made before and is important because of the way
Dr. Hirsch?
relates. Yes. Hello? Did somebody want me to stop talking?
Yes, now you're back, sir.
Oh, I'm sorry. When did you stop hearing me?
No, sir, you were, it was
Oh, okay. The main issue
about 10 seconds ago.
I'm sorry. Should I continue?
Yes, please.
Hello? Okay. I would say because the question of steroids came up, I would just point out that you know, in other aspects of my work, I study steroids quite a bit, and of course steroids can be harmful. We are talking about relatively low doses here. CGS itself provided references for this call. One I wasn't familiar with, so thank you. I would draw attention to Kim et al., which was one that CGS provided, because I think it's important if it is used to frame the discussion. They reported in the Journal of European Radiology 12,000 procedures of intra-articular facet joint steroid injections. I have that article up on my screen, and they reported adverse events in 99 patients, which is 1.63% per patient. The complications were actually astounding to me, with 7 cases of infectious spondylitis, One progressed to systemic aspergillosis in the spine. One had uncontrolled infective endocarditis. Some had neurological sequelae. I mean, for practical experience, I don't think somebody in Boston would get very many referrals with those types of numbers, and they really did not typify what I have seen in the literature, or I think the perspective that whereas there's debate, as we heard, about the efficacy of some of these procedures, not very much about the safety. In 2012, Manna Conti, who is a panelist on this discussion, looked at 7,500 episodes using medial branch block over 18 months in a high volume practice with 3 full-time pain physicians. In contrast to Kim, none of the cases required hospitalization or developed major infection. I think that's the perspective most people have. I would be remiss if I didn't state that infection is a possibility with both facet joint injections, intra-articular, medial branch block, or frankly, any intervention that we do. In this context, I think it's worth noting on what the question I think was alluding to is that in common practice, steroids are not used in medial branch blocks, but they are in intra-articular facet joint injections. So in my mind, both of these procedures are safe. If we're thinking about facet joint injections, the Kim article, which was provided by CGS, and we're thinking about the use of steroids, I would perhaps say that it's associated with moderate risk and give it a 3. My confidence level regarding medial branch blocks, which don't involve steroids typically, is high. I think the data is strong, and I would give that a 4 or even a 5. Thank you.
Thank you, sir. Dr. Kennedy, can you proceed to question number 5?
Sure. The question is, what is your confidence in the clinical literature to support the efficacy of facet joint interventions in each of the following regions: cervical facet, lumbar facet, and thoracic facet? Clearly, there's overlap with other sections, and we talked facet joint interventions that would include intra-articular steroids and radiofrequency. And really, to give due justice to each intervention at each spinal level is beyond the ability of what a 3-minute response allows. I'll therefore really try to provide some overriding themes around the 2 most common procedures: corticosteroids and radiofrequency denervation. An injection of corticosteroid in the facet joints or even along the medial branches has really been evaluated by several studies ranging in rigor from pragmatic outcome studies to placebo-controlled explanatory studies. The majority of the literature is in the lumbar spine, but studies do exist in the cervical spine as well. And the literature is highly variable in reported outcome, with quality studies showing both no effect and profound results. This is likely due to the fact that corticosteroids are physiologically active medications and thus more likely to successfully treat a physiologic process such as inflammation. In small studies, it specifically selected patients based on radiographic markers of inflammation such as T2 or STIR MRIs or SPECT scans. Corticosteroids were found to be more effective than not. This is in contrast to other well-done studies that did not use this selection criteria and demonstrated a lack of effectiveness. Radiofrequency neurotomy of the medial branches has a large volume of literature, including placebo-controlled explanatory studies in both the cervical and lumbar spine. Less data exists in the thoracic spine due to the variability in the neural anatomy in this region requiring large volume blocks and lesions. Collectively, for the cervical and lumbar spine, the literature is among the most robust in the spine world. The reported outcome from RF procedures do vary between studies. However, this variance appears to be at least partially predicated on the rigor of the diagnostic criteria used for subject enrollment and the technical details of the procedure. Given facet prevalence has been reported at 15 to 45% in the lumbar spine and 36 to 67% in the cervical spine, if studies do not adequately exclude those with facet-mediated pain without it, they would enroll more subjects without facet-mediated pain. When viewed in this manner, studies such as the MIT trial quickly become clear outliers, with 72% of subjects having a positive block. This number is divergent from any other published literature on the topic. Increasing diagnostic rigor with more blocks and greater percent relief tend towards more profound outcomes. However, this is at the expense of potentially denying an effective treatment to some due to the known possibility of a false negative block. In fact, if we look across multiple well-done studies with appropriate technique and selection criteria, reported results of 100% pain relief post-RF has been reported 46 to 70% of subjects at 6 months. This has also been reported with an associated reduction in opioid use, increased function, and even decreased overall healthcare utilization. So even after subjects are enrolled in these studies after having typically failed conservative treatment, this body of literature demonstrates a much greater efficacy than any conservative treatments, which according to the 2016 AHRQ report on non-invasive treatments for low back pain, which stated, quote, when present, end quote, observed benefits range from 5 to 20 points on a 100-point scale. To remind the group, this is otherwise what we would call clinically not significant. And they also said, quote, effects on function were generally smaller than effects on pain, end quote. So while the interventional spine and pain societies really debate whether 50%, 80%, 100% single or dual blocks are required to have sufficient relief for a procedure with a strong safety profile, other conservative treatments we are told to pursue generally fail to even reach the MCIC and controlled trials, even when compared to waitlist or other treatments that likely produce a nocebo effect. Over.
Excellent. Thank you, Dr. Kennedy. So before we leave this section, do any of the panelists want to provide any additional opinion regarding the body of discussion we've had regarding the procedure efficacy?
This is Dr. Manchi again. I think we still are questioning in giving a rating. Is it intra-articular injection or medial branch block? That is the confusion I'm having, at least in my mind, and many of the panelists, I think. Commenting on Dr. Kennedy, he did a great job. I don't have any issues with radiofrequency neurotomy or intra-articular injections, but I do think there is an issue with facet joint nerve blocks. Actually, there are more studies supporting facet joint nerve blocks, and more recently, even in thoracic spine, the evidence is level 2 across the board for lumbar, cervical, thoracic, all regions, with moderate strength of recommendation. Again, there is a mechanism is different. If we stick to this acute pain model, 2 hours, 45 minutes relief, that is not going to work. And we have to go into chronic pain model. And some of the studies he has quoted are that done in workers' comp injuries, motor vehicle injuries, and Australians. Americans are different. Medicare population is different. So we need to take into multiple variables into this consideration. Thank you.
Yeah, thank you, Dr. Manchi.
One more item here, please.
Dr. Tracy, please.
Yeah, this is Dr. Tracy. I also had confusion on question 4, whereas Dr. Hirsch so eloquently stated the use of steroids. The way I interpreted was repeat injections beyond 3 as we approach epidurals. We're allowed to do 3 in a year. So the way I interpreted that question was, what would you think if you did more facet injections in a year than 3? I don't know if I'm right or wrong on that, but my score changes in terms of the essence of the question.
Thank you for that clarification. The question emphasis will be on injections beyond 3 injections per year.
Okay, so I would then like to hear Dr. Hirsch's response to that, please.
Certainly.
Can you hear me?
Yes.
Yes.
So I think that there's some confusion in general as it relates to 3 a year. If you look at the MPW generated letter where most of the, I should say the SAS generated letter where most of the MPW participated, and by way of clear disclosure, I'm involved with multiple societies that signed on to that letter. There's discussion about 5, and here there was a question about 3. I think that part of the challenge is differentiating between diagnostic and therapeutic. And when I looked at the coverage programs for CGS versus some of the other CACs that are, MACs that are on here, I think that's also reflected in how the procedures are supported. The 5 interventions, I think, accumulates both the diagnostic and therapeutic, as people in general are not, I think, giving 5 therapeutic injections over the course of the year. I think as it relates to medial branch blocks, which customarily do not include steroids, you can really, from a safety point of view, give 3 or more without having to worry about safety, because again, the literature that I saw, I saw quite a bit and referenced the Manna Conti paper of 7,500 episodes, really reports no serious adverse outcomes to that. The Kim paper gives me a little pause. It does talk about facet joint intra-articular injections. I think that whether it's on the basis of that or on the basis of the fact that you're using steroids more typically, I would not be comfortable with the number 5, but it does seem to me that 3 therapeutic injections would be okay. But for the reasons I outlined before, I would recommend the same numbers that I did differentially for medial branch blocks versus intra-articular facets for the question of 3 or greater.
Thank you, Dr. Hirsch. And I appreciate that input from Dr. Tracy as well. So for clarification, please answer the 4th question based on beyond 3 injections per year. In regards to the 5th question, base your answers currently on intra-articular injections as opposed to the medial branch blocks and breaking those down as the primary procedure for the cervical, lumbar, and thoracic facets that were asked. As we move to section 2, and this actually goes right with Dr. Mannaconti's prior statements, we're going to talk about patient selection and the chronic pain patient and the degree of rigor in which we need to assess to provide these types of procedures. So I will turn the time over to Dr. Mannaconti.
Thank you, sir. Again, on question 5, you are saying that relates to only intra-articular injections. We were under the impression that when you said facet joint interventions, that's why Dr. Kennedy talked about radiofrequency so much, and then we talked about facet joint nerve blocks. So is that only intra-articular injection, or does that include all 3?
No, I would like to focus primarily on the intra-articular injection part of that question, and I apologize for the lack of clarity in that question.
Okay, so I will read my question. Does the literature support the statement, rigorous beneficiary selection and inclusion or criteria are necessary to reduce false positive diagnosis and false positive error rates when using facet joint injections and procedures? We all know that false positives are extremely common, even utilizing 80% criterion standard with a chronic pain model. We have shown that false positives in lumbar spine are 27% to 47%, in cervical spine 27% to 63%, and in thoracic spine 42% to 58%. However, if you use the single block technique, false positives are going to be much higher, especially if you use a 50% relief. So as I stated in the beginning itself, appropriate selection criteria is crucial for facet joint interventions to avoid unnecessary diagnostic and therapeutic interventions and to reduce false positive. Physical findings pointing towards facet joint pain are extremely crucial. Last night I was talking to one of our old professors, and he was saying that, Lax, don't forget the patient. Physical examinations, mention that. So that's what I'm doing here, as my professor told me. Thus, physical examination and clinical assessment are strongly recommended with axial pain, tenderness over the facet joints, reduced range of motion, pain reduction with rest, absence of radicular pain. However, this can only lead towards potential diagnosis, but not actual diagnosis. The imaging is not diagnostic. There is some evidence for SPECT, but nothing else. So consequently, we have to do the rigorous beneficiary selection and inclusion criteria. That is what improves the results rather than just going and sticking needles based on our instinct. So examination, pointing towards that and conservative management, duration, these are extremely important. Thank you.
Okay, thank you, sir. So the answer is you're saying yes, correct?
Yes.
And do you have a standard that would be considered, using the literature, that would be a rigorous standard for beneficiary selection?
Well, just this thing, axial pain, and if it is radiating, it should be somatic type of radiation, not radicular type. The tenderness over the paravertebral region or facet joints. If tenderness is mostly in the middle of the spine, that is not going to be facet joints. Reduced range of motion, pain reduction with rest, absence of radicular pain pattern. These are the important ones. Extension is sometimes helpful. There is also a new sign called Kemp sign. They are describing, but it is not clinically used that much. These are the ones we use. There have been many descriptions in the past by other investigators, but they have been proven to be inaccurate, so we no longer use them.
Thank you, sir. I'd like to move to question 2 as a way to build on Dr. Manciani's, and turn the time over to Dr. Moss.
Thank you, and I appreciate the invitation to be here. Question number 2 is the use of non-specific assessment of subjective, quote, pain reduction, unquote, reported by a beneficiary with non-specific chronic axial spine pain not associated with radiculopathy or myelopathy is a reliable and valid measure of improvement in pain following a facet injection or medial branch block injection. I would score that 4, referencing the medial branch block, not the facet injection. And here's my reasoning. The question addresses the validity of patient-reported responses to a diagnostic block. Validity of a test should ideally be measured against a physical criterion standard, which is indisputable, such as an observable pathologic finding, but no such criterion standard is available. Practically, the goals of interventional spine procedures are reduction of pain, restoration of physical, emotional, and social functioning, and reduction or elimination of consumption of healthcare resources. The subjective symptom of pain is fundamental. From chronic pain arises the deterioration of physical, emotional, and social functioning and the demand for healthcare. These secondary measures are not amenable to measurement in the time of effect of a local anesthetic, but longer-term neural blockade is an area of active investigation that may allow such in the future. Medial branch blocks exhibit phase validity or target specificity in both the cervical and lumbar spine segments that reaches the nociception of the facet joint. Medial branch blocks exhibit construct validity, the ability to discriminate a true positive response from a false positive response in both cervical and lumbar spine segments. The evidence is less robust in the thoracic region. False positive rates, however, range from 29% in cervical medial branch blocks to 38 to 45% in the lumbar segment, hence the need for controlled block. A dual comparative paradigm is a practical solution with a sensitivity of 100% and a specificity of 65% in the cervical region. This is reduced in the lumbar region where facet-mediated pain is of lower prevalence. It could be argued that in the absence of an actual criterion standard, the construct validity can't be obtained, that one can only obtain credibility. That is, how unlikely it is that the pattern of block responses expressed by the patient is due to random guessing or chance on the part of a beneficiary. And here you might want to consider a non-painful patient seeking to create the fiction of a pain state. Bogduk and Engel elegantly demonstrated mathematically by using 2 randomized comparative blocks the credibility is indeed high at 75%. The ultimate proof, which allays the concerns regarding the credibility of patient responses, is predictive validity. Does the block paradigm predict the response to a therapeutic injection? and that the therapeutic intervention, radiofrequency ablation being that therapeutic intervention. A recent systematic review of lumbar medial branch blocks in RF by Schneider and colleagues stratified the outcomes of radiofrequency ablation by the rigor of the medial branch block selection criteria. As the MAB selection criteria are tightened from single to dual comparative blocks, and the criteria for a positive block is elevated from 50% to 80% to 100%, the proportion of successful RF procedures increases. At the most rigorous level, where complete pain relief with dual comparative blocks is utilized, the RF procedure results in complete relief of pain for at least 6 months in 55% of patients, accompanied by restoration of function, return to work, and no need for other healthcare for a median duration of 15 months per treatment in the work of McVicker and colleagues. None of these above noted validation literature applies to intra-articular facet injections. As has been noted previously, these injections are subject to a higher technical failure. They may not have face validity due to a lack of containment of an injected anesthetic, and they're therefore not the preferred diagnostic approach. Thank you.
Excellent. So again, this is dealing with the Medicare beneficiary population. And so you're saying is essentially that the subjective pain reduction would be insufficient documentation to show efficacy of this patient, correct?
No, I'm saying that reduction of pain reported by the patient is the best documentation we have at this point. We don't have an absolute criterion standard. And because of the predictive validity exhibited by utilization of patient-reported pain responses to medial branch blocks, it is indeed the appropriate qualifying procedure for the definitive therapeutic procedure of radiofrequency ablation. It would be ideal if we could make functional improvements, but that's not possible at this time due to the limited temporal duration of local anesthetic blocks.
This is Dr. Schwachman. I agree. You know, what we do, I don't care how you cut the mustard. If the person says my pain is relieved, that's where we're going for. And after that, with respect to other things that he can do, so be it. But the main thing we're going for is pain reduction. If the patient's happy, and we're ahead of the game.
This is Dr. Manna Conti. Can I make a comment, please?
Sure.
The pain reduction is the main issue, our main way we judge the people, but there is also another component that immediately we examine the patient and they should be able to perform previously painful movements with continued pain relief. Otherwise, it's considered as negative. So a patient says 100% relief in prone position, but they can't sit and stand and do anything which was painful prior to that, then it will be considered as negative, in my opinion. And that is what literature says, and LCDs already state that there should be pain relief of the ability to perform previously painful movements.
I'll address that in a subsequent question, which I am asked to address.
Thank you, sir. Yeah, there is going to be some bleed over, and I appreciate that. I'd like to move to Dr. Simopoulos and his question number 3 regarding the numeric pain level. You can read that, please.
Sure. Thank you, everyone. A lot of this has already kind of set the premise for the answer for this. Do you have an intermediate confidence that there is adequate clinical literature to support a minimal numeric pain value, either NRS, VAS, or similar threshold, i.e. 6 out of 10, to identify an individual's pain level before a Medicare beneficiary is eligible for a facet joint injection or procedure? It was kind of because it's kind of complicated a little bit at the end, I interpreted this as, is there a minimum pain score to which we would consider a patient for a facet joint diagnostic procedure first? If we look at the literature, whether it's Dr. Manna Conti's work, Dr. Bogduck in the past, Dr. Derby, all of these studies had patients, as Dr. Manna Conti alluded to earlier, people who've had long-term pain and significant pain with movements. So there's always a mixture of factors. And so in conclusion, looking at the literature, there's not a minimal number or a number that's minimum for doing this. That said, a patient has to have an adequate level of pain that you could then assess and get a degree of relief. So if I go purely by the literature, there isn't a study that says this is the minimum number. So I had to say no on the studies if we go purely by the science.
Excellent. Thank you, sir. Going to move to question number 4, Dr. Schwashman.
Yeah, what you're saying on the one hand is what are the criteria for doing this? And on the one hand, you're asking about a number, and that's more like playing bingo, very frankly. On the other hand, the approach that Dr. Manchin is taken, now I said pain relief, but certainly the degree of satisfaction in motion and where the patient stands, sits, and so forth is what's really important. And there are various inclusion criteria, for example, and I do have a contract with Cigna, but I'm just a contracted provider. Cigna's got some very good criteria for doing this. And Dr. Manchin mentioned criteria for doing this. So when you do if you're going to do the blocks, I think you have to use inclusion criteria, as apparently Dr. Manchin does, rather than just pick a number like bingo out of the air. And there's not only inclusion criteria, there's also exclusion criteria on doing these cases, such as a fusion situation. So I think that whatever those inclusion criteria are, you can pull them from various sources, including Dr. Manchin.
May I speak?
Yes.
This is Dr. Tracy. I'm a little bit disappointed in that we've used the numeric rating scale to assess pain for decades. So we have to have a score to assess the pain. And what I do is explain to the patient, 1 is no pain, 0 is no pain, and 10 is the worst pain you've ever had in your life and you're in the hospital. So we have to have something to be able to rate the patient's pain. And, you know, if I'm not understanding this right, please interject, because what I'm reading here is the numeric scale or the visual analog scale a useful methodology? And I say yes, that it is.
So let me ask
This is
just
Dr.
Moss.
Go ahead. This is Dr. Kramer. Just commenting on Dr. Tracy's, I disagree. I think that the numerical pain rating scale is not useful. I think as a physical medicine or rehabilitation physician, I identify pain as it impacts a person's function. And I don't feel that the numerical scale really is able to reflect that. And I don't agree that we should be using the numerical rating scale for the determination of these types of procedures. It should be based on a patient's discussion of how this pain interferes with their functional activities. And pain ratings can vary depending on whether they're sitting in our office, whether they're physically doing an activity. So I think that that also has an impact, and it's not very helpful to use an NRS scale. That's my opinion.
I'm sorry, this is Stephen Cohen. One thing. So there have been a whole bunch of studies, about 5 or 6 studies, and they've shown that there is high correlation between verbal rating scales, numerical rating scales, the AS scales. The same scale should be used with the same person. Don't switch from one to another. But this is the question that I think that you're getting at, and this is what the impact guidelines say right? That you shouldn't just look at, pain. And what Dr. Manna-Conti said is absolutely right. If people are sedated and they're just, lying on a stretcher or go home and sleep for hours, that doesn't make sense. But this has been looked at actually by a physiatrist. Guy Magari published something in 2011. And, there's not a great correlation between pain and function, between patients. But there is, if you're looking at improvement in function within a patient in a longitudinal study or over a given time period, it's very highly correlated. So if people report 50% decrease in their pain, then they have improved function. So however you want to do this, if you're talking about a medial branch block, the problem with using something like a Swestry disability is there are questions on it that say, how is your, how do you travel? So they're not driving, or neck disability, can you drive? There are questions about sleeping. There are questions about sex. And so if you're using bupivacaine or lidocaine that's going to wear off in 3 hours or 6 hours or 7 hours, you're not going to be able to actually have a very good, index as to whether or not, function is improved. So there is, like I say, a correlation within a given patient between improved function and improved pain relief.
This is Dr. Schwachman, if I can comment. Your statement about within the patient is appropriate and true, because I've had patients that if I compare the before and after, I can get a number, although as Dr. Manna-Conti said, it's more valid if you can get motion. However, if this question implies that Medicare would say that you have to have a number 5 score or 7 score before you can have the block, then what you've done is you've compared patient A to patient B, and as Dr. Kennedy just pointed up, it doesn't quite work because one person will exaggerate pain levels and another person just shrugs off pain and so forth. So comparing, using that system to decide whether or not you're going to do the block, I think is like playing bingo. The guy's got to hit the right number, he doesn't get the block, as opposed to the inclusion criteria of what he can do, what he can't do before and after an injection, or what are his problems now from inclusion criteria. And we have this from various people, like Cigna, for example, has a nice layout for that. And I'm sure Dr. Manna-Conti also has a nice layout for who we would block and who we wouldn't.
So you're 100%. A 3/10 pain in some people is equivalent to 10 pain in other people. Any 0 to 10 pain scale is not linear, right? So the difference between 8 to a 6 that's much easier to obtain than a difference between a 4 over a 2. So you cannot have a cutoff like this. And for clinical trials, if you look at clinical trials, FDA or NIH sponsored, it's 4, sometimes 5 is the cutoff. So 6 definitely doesn't make sense.
This is Dr. Manna-Conti. Can I comment, please?
Yes, sir.
Here, the question was related to the diagnostic blocks. So how we select the patient and how we assess. So
that's correct.
6 may be about anything above 5 was the reasonable thing. And one of the insurers says 3 on their policy, but they were investigating us for not documenting 3 or 6. We were documenting average pain. So these issues go on with a lot of understandings. But my comment was mainly related to immediate testing of the patient. So a patient is lying down after the diagnostic block, so we don't send them home saying that he's pain-free and don't document that it is 100% relief. Rather than that, we make them to go through the various movements and then see. When they come back, that is when we actually look at their work status, sitting, standing, walking, lifting, carrying, mood, sleep patterns, all these other issues. That is more like a long-term relief. If a patient gets 3-4 weeks of relief, that is the thing we are looking at it. And after that, even 8 weeks or 13 weeks or 6 months with radiofrequency neurotomy. So those are the long-term ones. But for immediate evaluation, that is what we were looking at. Actually, Cigna followed ACIP guidelines, old guidelines. Now they are not, I don't know what they're following now, but those are the same. Mine and theirs are the same. Dr. Schwab.
Yeah, I'm just worried. It's Dr. Schwab again, if I can. I'm just worried about situations where you're going to pick a number and then after that permit the procedure to be done. In my experience, some patients don't understand the numbering system. You try to explain it, as Dr. Tracy said, and it doesn't always come across with people. And now you're taking a particular number. I think you're better off in deciding whether this can be done, or that Medicare will agree with it being done, or insurance company agreeing it will be done, that there be criteria to be that you could lay out and at least give a little story of where they can function and can't function, and then allow it to be done on that basis. The success of it afterwards is what Dr. Manchin is talking about, I think. But whether or not the patient will be getting the treatment, I think should include inclusive criteria and exclusion criteria, and not just pick a number like we'll do it if it's a number 3, but we won't do it if it's a number 6 or vice versa, because that's just playing bingo and the patients don't always understand it.
So I believe you're understanding that question correctly. So Dr. Moss, go ahead.
I just want to say I completely agree with the aforementioned comments that we have to be careful about discriminating the appropriate use of an NRS scale for measurement of a block response versus here we're talking about a patient being eligible for a procedure where we want to look not just at pain, but we want to look at physical, emotional, and social functioning as well. So looking at a broader profile, for example, the PROMIS profile paradigms would be a much more useful, valuable tool. Thank you.
Thank you. I'd like to move to Dr. Tracy on question 5 for have her address the issue of conservative treatment. If she could also, go into some detail about that and the duration of 3 months.
Well, I have to concur with Dr. Kennedy and Dr. Cohen and Dr. Manchin because it's very difficult to answer these types of questions in 3 minutes. So my answer to that question would depend on the intent of the question. Are you asking, does the clinical literature support conservative for a minimum 3 months just prior to the facet injection or median branch block? Because most of us have patients who've been through rounds and rounds and rounds of conservative therapy for years, decades. And so if that question is meant to support 3 months of conservative therapy just before the facet injection, I would have to say no. That I would not think that that would be the case. But if they failed rounds and rounds of conservative therapy for greater than 3 months, then I would have to give that a high score. Now, in your literature, in your bibliography, in trying to control time here, I just numbered the references in papers number 2, 3, 5, 6, and 1, and they failed 3 months of conservative therapy. They didn't say if it was most recent or after that. In papers number 7 and 12, they talked about 3 months of pain or symptoms. And one of those was Dr. Manchin, who did 12 randomized and 5 observational studies. And then in Articles 19, 20, and 7, it was greater than 6 months of pain. And in Articles 9 and 10, it was greater than 24 months of pain. So you would have to clarify for me what you mean by the conservative therapy. Also here, we're talking about the Medicare population. And in one of Dr. Mancini's papers and in his draft outline on page 96, he says there's a significantly higher prevalence of facet joint pain in patients over 65. So most of these studies in the bibliography have patients of all ages in it and not over 65. So I would agree with Dr. Manchin and the ACIP guidelines on page 96. I think you have this draft and it'll be published tomorrow, that it's more common in the population we're talking about, i.e. the Medicare population. But also on page 61 of the newly developed ACIP guidelines, it says that there is level 2, and in this evaluation, level 2 is a high level, level 1 is the highest, and selecting patients for facet joint and nerve injections at least 3 months after onset of failure of conservative therapy. So, you know, I'm not sure how to answer that. I think that anyone suffering for 3 months, some of my elderlies actually cry when I ask them to undergo physical therapy. They're so debilitated. My practice is 90% Medicare, 80s and 90s. And so I would prefer the 3 months of pain than the 3 months of failed conservative therapy with some judgment factors added to that. Thank you.
Okay, thank you. So it is more according to the guidelines that you're alluding to. And when we're speaking in general terms, the minimum of 3 months of conservative treatment prior to just someone coming in de novo without any prior treatment to get an injection.
Okay, so you would say that years of conservative therapy greater than 3 months would be adequate in that question?
Yes.
Okay, so then I would say yes, that would get a high degree, a high score from me.
Excellent.
And I would give that a 4.
Thank you.
This is Dr. Manchi. Can I comment?
Please.
So 3 months of, Deborah did a wonderful job there explaining her position there, and I agree with most of it, but why 3 months? Why not 1 month? Why not 8 months? Why not 12 months? There is no reason for that. Why would you put somebody for 3 months of physical therapy if it is hurting them? They can't even go to physical therapy. They don't want to go. And at the same time, if somebody is able to perform appropriate exercise program self, or they have seen a chiropractor on and off, altogether they had the failed conservative treatment. Our guidelines and LCDs always said that 3 months after the onset of the pain with failed conservative treatment. That means conservative treatment did not work or did not provide adequate relief. But once you say that 3 months of conservative management, so a person has to have pain for at least 6 months now, or even longer, because they have to wait, see the doctor, then go through the physical therapy and everything else. It is going to take a long time. So I think that limit maybe a good idea to go ahead and remove it and then say non-responsive to conservative management in general terms, including physician-ordered physical therapy, chiropractic, medication therapy. We can add all those things, but still it should be left to the patient and doctor and their financial situation. There are huge deductibles these patients can't afford co-pays. I'm sure we don't want to bring the cost here, but it is going to be a factor to them. So they are going to cry, as she said, when you order them physical therapy. I already failed it so many times. Why do you want me to go through that?
Yeah. So this is DJ Kennedy. I'm going to agree with Dr. Manna Conti. The number is somewhat arbitrary. On the pro side, the literature does support 3 months as a prerequisite purely because that is how the studies were designed in terms of their enrollment for subsequent interventional procedures. If you take the flip side and ask, are there studies on conservative treatment that they require 3 months before they are shown to be effective, the answer is simply no. The best studies we have on this are on some of the chiropractic treatments, and it's somewhere in the nature of 8 visits, if it's shown to be effective. So, there is that literature showing that, yes, maybe 3 months waiting is what a lot of the enrollment criteria was there for. But again, that is not based upon any mechanism of action for the conservative treatments across the board.
This is Stephen. I think my question is very related, so you can just skip over this. So I agree completely with what Lax and DJ said. So you should require conservative treatment. So if you look at the randomized controlled trials examining, Facet radiofrequency denervation, only 2 did not require it: the Van Wyck study and the Leclerc study, and both were negative. Guidelines from NICE, guidelines from the Belgian Federation of Healthcare Institute, the step care model for the VA, which is being adapted by, at a lot of military treatment facilities, requires conservative care. And finally, there's a validated, instrument for evaluating epidural steroid injection studies. And there are a lot of people from all over the world, experts from Asia, from Europe, Van Zundert, who has a PhD in pulsed radiofrequency, Mark Huntoon, who at the time was the editor-in-chief of RAPM, Chad Brummett, and they concluded, it's called Aquarius, that 3 months should be required for epidural steroid injection study. And the reason for this is that if you treat people with epidural steroids in a randomized trial, you're going to be more likely to not show benefit because these people will get better on their own. But it's the same thing with Facet. If you're treating people with, most people who have back pain for 5 weeks are going to get better whether or not they're treated. So if you treat them at 5 weeks with Facet denervation and they get better, and let's say they get better for 15 months and then their pain comes back, what happens in reality is they get treated again and again and again, and it's really difficult to know if they work. So you need to require conservative treatment. Everyone agrees, but I agree with Lax and with DJ that we don't know exactly what that is. It may not be 3 months. Maybe it's, maybe it's 8 weeks. Maybe in some people it should be more than 3 months. And you can skip my term because I think it's almost the same question.
Yeah, you're actually correct. It's just a little slight variation of it, and I believe you addressed it very well. So let me drop back to Dr. Barnhill to address some of the conservative treatments that would be considered in a policy.
Thank you. Can you hear me okay?
Yes, sir.
Thank you. My question is, do you agree the following modalities are considered conservative treatment? And the simple answer is yes. When I looked for evidence, that was a little bit more difficult to find supporting evidence. However, I did find protocols and guidelines. So I'd like to share you comments on each of the modalities listed. Current low back and neck pain protocols by the North American Spine Society and regional insurance carriers recommend these modalities prior to a pain specialist evaluation. However, our Dr. Cohen in 2014 identified this practice as a fundamental medical principle in which you start with the less invasive interventions. This recommendation by NAS and insurance carriers is not supported by conservative therapy outcome studies. However, that was Dr. Cohen, Additionally, another problem identified by Cohen in his 2014 article relates to the timing of the proposed conservative therapy, either before or in conjunction with spinal interventions for low back pain. So as far as integrative treatments, I said yes, acupuncture is considered an effective treatment for selective acute and chronic pain syndromes and is therefore a reasonable referral option. Significant difference between true and sham acupuncture indicate that acupuncture is just more than a placebo. However, these differences are relatively modest, suggest that factors in addition to the specific effects of needling are important contributors to therapeutic effects of acupuncture. That's based on Vickers 2012. Currently, the Academic Consortium of Integrated Medicine and Health Commentary to CMS acknowledges that acupuncture is recommended by the American College of Physicians, the National Institutes of Health, and the U.S. Agency for Health Care Research and Quality for chronic low back pain, and is among the primary treatment options recommended for chronic low back pain and neck pain without serious pathology by the Global Spine Care Initiative. While older patients were not excluded in trials that supported these recommendations, acupuncture for chronic low back pain, specifically in the elderly, has not been adequately investigated. That's based on ARA 2019. Now, as far as spinal manipulation therapy, a multimodal approach, including spinal manipulation therapy, other commonly used active interventions, self-management advice, exercise, were effective treatment strategies for acute and chronic back pain, with or without leg pain. A meta-analysis by Riddick in 2016 revealed that spinal manipulation was superior to sham therapy for non-specific low back pain. Smith in 19 considered osteopathic manipulative therapy as a grade B level of evidence. For patients with acute low back pain, spinal manipulative therapy results in similar outcomes to no treatment, medication, or modalities. Periodically, short-term improvement is statistically better, but clinical significance is uncertain. As far as physical therapy, it's recommended by NAS and insurance carriers prior to Facet injections. However, the NIH Care Excellence and the Belgian Federal Healthcare Institute recommend therapy in conjunction with low back pain protocol that includes RFA. Not enough evidence to evaluate treatment results. As far as medications, anti-inflammatories, antidepressants, yes. The NAS once again recommended 3-month trial before Facet interventions. As others, nutrition, weight loss, hygiene, yes, I have extra. Sensation and stress will be added to this list of pre-treatment for the therapy. Also, it may abolish some of the presenting symptoms and prepare patients for self-care after this bout of painful experience. That concludes my comment.
Thank you, Dr. Barnhill. I appreciate that. You took a very tough question and you did an excellent job. If we could move to question number 8 with Dr. Kramer.
Okay, so the question number 8 is, does the clinical literature support at least intermediate confidence that history and physical examination can be used to identify a painful facet joint as the primary source of pain? Dr. Conte presented in the World Journal of Orthopedics, this was in May of 2016, a review. His conclusion in that regard attempts to make the diagnosis of lumbar facet joint pain by history, identification of pain patterns, physical exam, and imaging techniques have shown low accuracy and utility. There was an article published in the Journal of Pain Physician in 2012. This was a multivariate analysis of the relationship between pain referral patterns and the source of chronic low back pain. This was authored by Ben LaPlante. He concluded the presence or absence of thigh pain possesses a significant correlation on the source of chronic low back pain for varying ages, whereas the presence of hip girdle pain or leg pain did not significantly discriminate among intradiscal disruption, facet joint pain, or sacroiliac joint pain as the etiology of chronic low back pain. He also commented that younger age was predictive of intradiscal disruption regardless of the presence or absence of thigh pain. I think the main indication or the main point that I took home from that was the varying impact of age, and that disc disease itself may mimic or have a similar pain pattern as what we would consider facet joint pain. Another journal, the Journal of Physical Therapy, which I thought was interesting because it looked at physical therapists who we might assume have a good understanding of pain conditions, and this was published in 2007, and they reviewed the topic, and their article is entitled Indicators of Lumbar Zygapophyseal Joint Pain, Survey of an Expert Panel with Delphi Techniques. And they went through various literature and reviews, and following 3 rounds, a consensus was achieved, and there are 12 indicators of zygapophyseal facet pain that they identified that reached the highest levels of consensus were a positive response to facet joint injection, and then localized unilateral low back pain. Positive medial branch block was number 3. Pain upon unilateral palpation of the zygapophyseal joint or transverse process. A lack of radicular features. Pain eased by flexion, and pain to refer located above the knee. And then referring back to Dr. Stephen Cohen's article, the pathogenesis, diagnosis, and treatment of lumbar zygapophyseal joint pain, and he concluded that in summary, no history or physical examination findings can reliably predict response to diagnostic facet joint blocks. And then getting into the more recent article, the consensus practice guidelines on interventions for lumbar facet joint pain from a multi-specialty international working group, regional anesthesia and pain medicine. Dr. Cohen also summarized no pathognomonic physical exam or historical signs that can reliably predict response to facet joint blocks. So I guess from a question point of view, I felt that the clinical literature did not support intermediate confidence that history and physical examination could be used to identify a painful facet joint as the primary source of pain.
Thank you, sir. We'll move to Dr. Kennedy now to discuss the issue of imaging, question number 9.
Sure, and just to clarify, I have no conflicts of interest need to be reported. The question is, does the clinical literature support with at least confidence of greater than 2.5 a requirement for imaging before prognostic blocks? I said no, but there is some evidence suggesting there's a utility in pre-procedure imaging, and there are additional concerns that drive providers to obtain these images. The most widely investigated imaging modality used to detect potentially painful facet joints is SPECT scanning, which does provide a measure of biologic activity, thus the potential to detect active inflammation. Some evidence exists about the ability of SPECT to provide predict a positive response to a medial branch block or an intra-articular facet injection, although there's really no data on cost effectiveness of routinely ordering this test. This, combined with the risk posed by radiation exposure, has really limited its routine usage. There's also small studies evaluating specific MRI sequences for inflammation that tend towards a positive predictive value. There is also additional studies on the presence or absence of facet arthropathy on MRI has been shown to correlate with a positive medial branch block, meaning if they have it, they're more likely to respond than if they don't have it. But the degree of arthropathy has not been shown to have a correlation. Collectively, there really is limited data that pre-procedural imaging enhances the outcomes from prognostic blocks on a population level. However, one study by Akithoto et al. Showed that 43% of procedures are changed based on the results of an MRI. It should also be noted that every practitioner I know has seen a contraindication to a spine procedure on pre-procedure imaging. Also, advanced imaging is often obtained for other reasons. Specifically, by definition, by the time a patient is ready for an interventional procedure targeting the facet joint, they generally met the criteria for advanced imaging due to the duration of pain and typically failure of other conservative treatments, as we discussed above. Thus, while the procedure itself may not require pre-procedure imaging, spine care and the current medical legal environment may mandate.
Thank you, Dr. Kennedy. It's a complicated question, and I appreciate the breadth at which you addressed it. I'd like to move to Dr. Manciani about question number 10, an objective documentation requirement. And again, this kind of gets back to the original, there's some of the beginning questions was, is a subjective pain score and a numeric analog scale, or should we be moving more toward more objective documentation? And turn the time over to Dr. Manciani.
Thank you. This is Dr. Manna Conti. I don't have any conflicts again. I think I already did that. So my answer is yes. Do I need to read the question? Okay,
yes, if you would, please.
Does the clinical literature support with at least intermediate confidence greater than 2.5 objective documentation, as in a daily pain diary should be required to measure the sustained percentage of improvement following the facet joint injections to relieve pain and improve function? Answer is yes. The clinical literature does support assessment of pain relief and improvement in functional status, and it is mandatory in most of the jurisdictions. However, I do not feel that pain diary is the best way to do it. It only reminds the patient of pain, the bad stuff all the time, and they don't complete it on time. People have other lives other than just reporting the pain diary. They write down some kind of number because that is what is required for you to get further treatment. So in my opinion, and according to the literature available, the best way to assess improvement is initially their pain levels along with oswosity, low back or neck disability index. For subsequent visits, we should look at not only what their baseline pain was, but what was the average pain, and also the pain during the time when they are presenting to you. That could be 50% of what it was before or more than. Otherwise, they may not even need a further treatment. And we need to assess the same things as I was talking before, their work status, sitting, standing. Are they improved, somewhat improved, or get worsening or the same? Lifting and carrying, mood and sleep patterns. These are the protocols we developed, and everybody has these things. So you document routinely, ask the patient the questions, and document routinely and move on with it. We can also evaluate how many of their goals have been met. We ask them initially what goals they have. For some people, just going to doing activities of daily living in our Medicare population is a major achievement. Playing with grandchildren or going for a walk, shopping, those are all important programs, important aspects. Again, they are participating in the structured exercise program or not. So we would like to see that before proceeding with the injection therapy, on the day of the procedure, we should document for that day that patient pain has returned to at least 50% of what it was, the baseline. So we have average pain relief, and then on that day what the pain was. Thank you.
Thank you, sir. That was very well done. If we could go to Tim, if you take on question number 11, please.
Thank you. Question is, I am confident that there is at least intermediate confidence in the clinical literature to support the terminology of temporary pain relief, long-lasting pain relief, and permanent pain relief as a reasonable, reliable, and meaningful health outcome in terms of objective clinical assessment for facet-mediated pain relief. I would answer yes, but provide some context to this, as I'm sure Dr. Simopoulos will on the subsequent question. First, regarding temporary pain relief, this references response to a diagnostic block, anticipated duration of a local anesthetic agent. The temporal duration of the effect, which is usually hours of these individual agents, is subject to significant individual variability. Temporary pain relief in response to a diagnostic block should be complete or near complete at 80% for the block to be considered positive. This is borne out by my previous comments on the predictive validity of medial branch blocks. When studies of RF neurotomy outcomes are stratified by the degree of temporary pain relief, responder rates for RF neurotomy significantly improve when more rigorous criteria for this temporary pain relief are instituted.
His response to queries regarding temporary pain relief also depend on how that question is posited and by whom. This again goes back to additional comments that have been previously made. An independent assessor, not the procedural physician, should be utilized to assess this temporary pain relief. And it must be made very clear to the patient what is the index pain we're studying with this block procedure. And if that pain is precipitated only by specific positions or motions, then these provocative maneuvers must be documented and performed. The subsequent question will address the definitions of long-term and permanent pain relief following a therapeutic, not diagnostic procedure, and I think it's very important to make that distinction. I wish to add some nuance to this by noting that patient-reported pain relief is by itself a pretty blunt instrument, and the literature for many years has noted that multiple additional domains of physical, emotional, and social functioning are necessary to be measured both in clinical practice and in clinical trials. These metrics recognize that for therapeutic endeavors, pain relief is not the endpoint, but the pathway to improve physical, emotional, and social functioning and diminish consumption of healthcare, including opioid use. Such an assessment of domains beyond pain intensity is available by the NIH-developed PROMISE system of patient-reported metrics, obviously support. And with computer-adaptive testing, this can very much minimize patient burden in this assessment. This or other consensus agreed upon broader metrics would provide a better understanding of the overall utility of Facet interventions rather than simply a pain metric. Thank you very much.
That was excellent. Thank you, sir. I'd like to move to Dr. Simopoulos. I believe you're up next, and this complex next question is breaking down a little bit more. Dr. Moss was addressing.
Sure, I think that a lot of this has been addressed in part in leading up to this question. First, does the clinical literature support the definitions of the following terms? And I think we've been through some of this. Temporary pain relief is defined as pain relief greater than 80% based on a minimum duration of action, relief consistent with the duration of the local anesthetic employed during the therapeutic zygopophyseal joint injection procedure or medial branch blocks. I think we went over earlier the diagnostic value of facet blocks versus medial branch blocks, and I think right now, most of us, including based on the literature, find that the medial branch block is the way to proceed with the diagnosis of facet joint-mediated pain, and that the majority of the literature is gravitating towards 80% or more. And finally, the idea, and Dr. Manna touched upon this, that this began by Dr. Bogduk years ago, that temporary relief defined by the duration of the agent was defined by either lidocaine or bupivacaine, and typically the relief lasts that long, although he accurately pointed out that that's not the case in many situations, and it tends to move more towards the long-lasting. So I would say most of us would agree that very temporary or transient relief would be the duration of the anesthetic. So then I'll move to part B. Long-lasting pain relief is defined as pain relief consistent with greater than 50% pain relief for at least 12 weeks from the prior therapeutic zygopophyseal joint injection procedure or medial branch block. And that is, most of us would consider to be short-term relief. That's another term used for this, but it is more long-lasting than the block in our chronic pain population. And I think that given the mechanisms that were discussed, we kind of went into that in particular. Lax explained that pretty nicely in our patients. So I do think that something that exists long-lasting has been borne out in multiple studies, both either epidural studies or facet joint interventions with either local anesthetic or steroids, that 3 months is not uncommon for patients in this area and do get lasting relief. And of course, as Dr. Cohen, many do not. Which brings us to the next area, which is permanent pain relief, is defined as pain relief that is consistent with greater than 50% relief for at least 26 months, typically the 6-month window here, from the prior facet joint, zygopophyseal joint injection procedure or medial branch blocks. A nice comparison was by the Lake-Meyer study in 2013, looking at the 6-month marker for facet joint injections. and radio frequency, at least in this small population where they compared neck to neck, both seem to have the possibility of even facet joint injections to render long-term pain relief. Facet joint injections can also be temporary or long-lasting. A lot of these studies are small, and there's some inclusion criteria that may vary a bit, and you see that I think suffice it to say these are reasonable definitions for what we seek to do. Again, permanent pain relief, pain that tends to go beyond 6 months, is also called long-term pain relief rather than short-term. So that's another terminology that I see commonly.
This is Stephen Cohen. I'm sorry, I have to comment here. So the trend is not towards requiring 80% pain relief. It's actually against that, and I will tell you how. So the impact guidelines, which say 30% pain relief is clinically meaningful, almost every single FDA-sponsored trial now, they look at responder analysis and they use 30% or 50%. The ORCI guidelines for osteoarthritis in general even require less than 20%, less than 30% sometimes. They have criteria that's 20%. Second, facet degeneration is really rare in the absence of disc degeneration. So nobody has facet degeneration, in isolation. There are many studies for this, Fujiwara, Weishaupt. There's a systematic review by Branch-Faceted in 2015 that shows, by the time you're in your 30s, more than half of the people who never had back pain have disc degeneration. But that cutoff for facet degeneration is 6 years. And there are so many studies that have looked at this cutoff threshold, and not just for facet, and there are many of those. We did one with 92 patients, cervical facet. We've done a couple for lumbar facet. Stojanovic did one for lumbar facet, no difference between 50 or 80% or 1 or 2 blocks. It's been done for spinal cord stimulation. A.O.D. Williams, it's been done for pulsed radio frequency. Jules Huang, it's been done for diagnostic procedures before superior hypogastric plexus and celiac plexus neurolysis. Again, no difference between 50%, or 80%. And there are studies that show that you get a higher success rate when you use 80% cutoff before radio frequency ablation. But I'm going to very, very briefly go over these. So you have Rick Derby's study, which had 51 patients, a retrospective study. And when he used 80%, which was how they classified a positive responder, the success rate was 84%. But when he used 50 to 80% pain relief, so these people, if you have an 80% cutoff, would never receive it. Never receive radio frequency ablation, and they may end up on opioids or getting spinal fusion or something else. The success rate was still 56%. So in other words, you're going to deny access to care to people who have 50, 60% pain relief, which the FDA, NIH, and the impact guidelines all say is clinically meaningful. And, there's only one prospective study that ever looked at this. And this was our study published in 2012 in Clinical Journal of Pain. And we designated cutoffs in 10% intervals. So 50 to 60%, 60 to 70, 71 to 80, 81 to 90. And there's no difference at all in radio frequency outcomes when, between 50 to 60% and 80 to 90. It doesn't make any difference. There were 6 people, we didn't expect this, right? Ended up having radio frequency ablation with less than 50% pain relief, and only 1 out of those 6 got better. But that's even a statistical artifact because this was a prospective study, it was registered. And so we pre-designated 50% pain relief and a positive global perceived effect at 3 months as the definition for a positive outcome. But these 6 people, they came in with 37, 38% pain relief. And they said, I know I didn't get 50% pain relief, but I didn't have to take my oxycodone. I was able to play tennis. I slept better. And so we did radio frequency on them. And although only one got 50% relief, there were 3 out of 6 that still said, I'm really happy. I feel much better. So 80% relief is not where this is heading. That's really, really old data. That's from like the early 2000s when SIS was, or even the 90s when SIS was coming out with these guidelines. But since then, you've had all of these organizations, come out and say that doesn't make sense. And it doesn't even mechanistically make sense because, as I said, you never get facet degeneration without significant disc degeneration and without significant myofascial pathology. And there's also a systematic review on that by Geiser in 2006.
May I comment? This is Dr. Tracy.
Dr. Tracy, go ahead.
Yeah, I would like to strongly support Dr. Cohen's position and refer you to the paper Dr. Barnhart referenced in the beginning of the session, the Consensus Practice Guidelines on Interventions for Lumbar Facet Joint Pain from a multi-specialty international work group. And that was spearheaded by Dr. Cohen. And on page 19, on page 20 of that article, it says, in summary, this committee recommends that greater than 50% reduction in pain be considered a positive block, although we recognize that studies should be performed to determine whether lower cutoffs may prove optimal. And along with Dr. Cohen here in Florida, our pioneers that moved from other states, you get them back to golfing and tennis and being able to perform, improve their functional ability. No matter how little you give them, they're as happy as a clam. Thank you.
Thank you, Dr. Tracy.
Dr. Manna Conti, can I comment?
Who gets 50% pain relief and is really, really satisfied a treatment when there are no options. And in fact, there are other options, but they're not good options, surgery or opioids.
This is Dr. Manna Conti. Can I comment, please?
Yeah, yes, please. And then, yes.
Okay. I think I'm not sure where Dr. Cohen is coming. We just completed a study looking at 50% and 80%. We did studies in 2000s, and our last study was not that old. And they also published 75% pain relief more recently. And there are several studies in the cervical spine which came with the 80% relief too. There are also studies which looked at 50%, 80%, and they couldn't even figure out what was happening at 50%. I'm not sure 30% relief is going to get them back to golf course, and it is not even worth doing an intervention. And we are talking about radiofrequency neurotomy. It looks like that's the only treatment. There are other treatments. These patients can respond to facet joint nerve blocks. We are moving more towards it rather than less towards it. We just have completed 2 papers which will be published in the next few months, showing again the same amount of prevalence and high false positive rates with a single block. Again, as I said before, we are looking at acute pain model and chronic pain model. Actually, Bogdak described the philosophical foundation for diagnostic blocks and differences of opinion. He said there were 3 schools. One was purist school based on their own approach, which is 100% pain relief and duration of relief of less than 7 hours or less than 24 hours. The second approach he described was a pragmatic approach by Dr. Cohen, who just talked. And according to that, Dr. Cohen goes on what he just said. The third one was a second school he called, was the approach described by me or us, which follows actually Bogdak's approach, but utilizes a different criteria of relief in reference to the duration of relief. Only thing he didn't like is that we were compromising with a lesser effective treatment. He thought facet joint nerve blocks do not provide the same amount of relief as radiofrequency. So we were of lesser effective treatment. So that is the only thing he did not like. But all in all, as we move forward, there will be more requirements and more of literature on 80%, and that will be more widely accepted than 50%.
And this is DJ Kennedy. I was going to speak up here too. I think part of the problem I have with this question is when we look at therapeutic response, of which it says therapeutic zygapophyseal joint procedures and our medial branch blocks, and differentiating therapeutic outcomes from diagnostic outcomes. We wish they perfectly mirrored each other, but they don't always, right? For a whole host of reasons. And Dr. Cohen is 100% correct. 30%, 50% therapeutic outcome is something that almost, who wouldn't take that, right? I mean, that's still better than anything else in the literature for axial spine pain, and by a long shot. The diagnostic procedures, it does change your predication in terms of where you're going and percentage of people that are getting a positive response. And part of this is when we're looking at, does 50, 60, 70, 80% change, it does not on a single block, right? It really doesn't. But if you start applying a more rigorous protocol, 80% in dual block, some of those, the literature trends towards a greater percentage of people having positive outcomes. However, there is a downside to this. And the downside is this pesky thing called a false negative, right? Where someone can have pain that would benefit, and this is what Dr. Cohen mentioned, in the Derby study, that you would be denying care to a subset of people. And I really think that's the question, is the goal here to treat the majority of people that could benefit from this, or to have something with a high response rate that is higher than anything else in the published literature. And, that's where you hear people arguing about 50, 80, 100%. I mean, these are all still significant cutoffs when compared to anything else in the literature.
So that is so perfectly said, and I want to tie this in because what Dr. Manna Conti said is also true, and this is from his 2010 article, retrospect, a study with 252 patients, and he looked at, this is the 1 year follow-up, and so he looked at 50 versus 80% pain relief. So a lot of the patients were on opioids. Not all of them got radiofrequency. Some of them got just serial medial branch blocks. But in the people who had greater than 80% pain relief, he reported an astounding 93% success rate, which was higher than the 75% success rate when he used 50%, but less than 80% relief. So think about this. So yes, as Dr. Kennedy says, and almost everyone agrees, that you will probably get, a higher responder rate if you raise threshold. But these 75% of these people who got between 50 and 79% pain relief, that's amazing outcome, 75%. And these people would never have been able to receive radiofrequency ablation if that cutoff was 80%. And when people were thinking of this 80% or 100% cutoff, this was a different world, because the most common cutoff for a positive response was 50%, right? It was the 50% club. If you got 50% pain relief, it was great. But now we know that that's not the case, that 30% is. So even acknowledging that you may have better pain relief with medial branch blocks, the 80% pain relief was coupled with 80% pain relief during the diagnostic block was coupled with a 50% pain relief during radiofrequency. So those were the dual outcomes. But now that we have 30% after radiofrequency ablation used in the MIN trials, used in the FACT trials, and used in this huge NIH $16 million study that we have on radiofrequency ablation, right? 30% pain relief. Now that you decreased it from 50% pain relief to 30% pain relief, which everyone agrees with, you still have this greater than 80% pain relief as a diagnostic cutoff. Tell a patient this, that I'm sorry, you only got 75% pain relief. We're not going to do this procedure.
I appreciate that vigorous interchange, and I think that's exactly why we're having this type of discussion. I'm actually going to make it a little more complicated now, and we're going to have Dr. Schwachman actually even start addressing some specific type of pain patients and trying to integrate that into the answers of the question.
Well, with this is Dr. Schwachman, if I may. We basically answered, because if you're going to have inclusion criteria, you're always going to have the opposite. For every pro, there's always a con. And there are exclusion criteria, and various companies have put it together after and put out good research papers. And I've cited the Cigna situation before. There are exclusion criteria in what Cigna does as well, and as well as inclusion. I would also add one statement. Dr. Manchin on inclusion condemned the idea of 3 months, and I would say that using 3 months or any number like that rather than the physician-patient relationship is frankly barbaric, because you have someone who may not respond to conservative therapy, and now he has to wait 3 months. And if you the exclusion criteria also have to be looked at. For example, in case of a fusion, you wouldn't want to do it.
Dr. Schwachman, I'd like to just press this question a little bit more as well. What happens now that you have a patient that has axial spine pain, but they have confounding additional diagnoses of widespread diffuse pain? Do we need to have additional inclusion-exclusion criteria that includes or excludes that complex pain group?
No, I think that you get complex situations. For example, you can have a diabetic have diabetic neuropathy, but he can also have disc disease as well. And sometimes you just treat the disc disease, and he's perfectly capable of living with his diabetic neuropathy. I think that you treat what you can, and that's what you do. You don't necessarily just say, well, this is an exclusion, and therefore you have to suffer the other parts of the disease.
So I'd be interested in the rest of the panel as well as providing some opinions regarding the complexity of overlapping low back pain etiologies. So Dr. Schwachman, I understand your point with diabetic neuropathy and degenerative disc disease, but those are in different, typically, locations. What I think the question and the complexity of this is, what if they have axial spine pain on top of fibromyalgia?
Well, I'm trying to say that if you have a cause for treatment, regardless of what other issues you have, you should try to treat it. I don't. You have to look at each individual issue of and by itself, and you might look at the periphery situation, but I think you should look at treating what you've got. And you've got facet joint disease. All that's been said today should apply to treating that facet joint disease. And I don't think that necessarily having other diseases would be a contraindication to treating facet joint disease.
So this is DJ Kennedy. I'm going to partly agree with that,
thank you,
partly disagree. You know, I agree completely. This is on an individual basis, and you have to evaluate the individual patient to see what is being done. And, you know, the question about does the literature support overlapping pain syndromes as an exclusion or inclusion for this? I don't think the literature supports that one way or the other, meaning we don't have studies that specifically included this group or excluded this group or controlled for that variable. And part of it is, as has already been highlighted, how are you defining it, right? Because diffuse widespread pain, right, I mean, could very easily fit with, you know, a peripheral neuropathy, right, or fibromyalgia or any other thing coming through. My clinical experience, and I am now into the realm of expert opinion, which is the lowest form of evidence because there is not a lot of written evidence on this, so I'm acknowledging that, is when I do get people with overlapping spine syndromes in their back, and I do, this kind of plays into the previous question, and I do a block and I get 20, 30% relief on them, is not a primary pain generator, not a substantial restoration of function, decrement, and medication use, the likelihood of me having a positive therapeutic response that is notable to that patient is not high. And, you know, I think that that's where it comes into the individual patient, because just because someone has widespread pain, they could have a major pain generator with functional restoration and decreased medication use with targeting an individual pain generator, or they could not. And, you know, it is hard to tease that out based upon any data, patient demographics, ICD-10 codes that we really have for these patients.
Thank you, Dr. Kennedy. That was well said.
May I make a comment?
Actually, Dr. Tracy, you're exactly who I was going to next, because I want you to make the comment, and I'm giving you the final statement and to answer that last question as well as to opine on this current issue.
Well, I would agree with Dr. Kennedy. Here in Florida, our elderlies have multifactorial back pain. It's very common to see an MRI image that has facet deterioration, inflammation, spinal stenosis, spondylolisthesis, herniated discs, bulging discs. And that's why we do a diagnostic injection, because if I see a patient that has a predominance of what Dr. Kennedy said previously, thigh pain, then, and they have radicular pain, but they say not as much and it doesn't hurt as bad, then I'll go ahead and do the diagnostic block and get the answer to that. So I would agree with Dr. Kennedy 100% on that, and I'm ready to move on, except if there's any other comments.
I have one comment. So I'm involved at 5 o'clock. In fact, I may have to cancel it. They're calling from Australia. That's why it's 5 o'clock. You know, I'm involved in this pain series with these people who are nosoplastic pain experts. So one is for Lancet, and I'm just revising it now for for pain. And it's very clear that people who have a diffuse pain phenotype fail all sorts of treatments. So absolutely clear. So Chad Brummett's group and Claw showed they have really widely aberrant responses. We published something last year in RAPM. The p-value was, there was a very strong trend. It wasn't high enough, and we have something coming out in anesthesia or analgesia. And the reason is because these people with diffuse pain phenotype, whether or not it's fibromyalgia or called something else, the main thing that's the matter with them is that their nervous system is just hypersensitized. So they have knee pain, they have abdominal pain, they have pelvic pain. So that's a separate question. So they're going to be more likely to fail treatment, but I'm not sure what else to do. But in terms of like etiologies, the same risk factors for facet degeneration are risk factors for SI joint degeneration. That systematic review that I cited by Geiser, no matter what your cause of back pain, people just have elevated myoelectric activity. They have, increased muscle tension in their back. And there's, work by Milan Stojanovic in that other systematic review I pointed out. These people all also have, stenosis, foraminal stenosis, central stenosis. In Milan's 2010, article, he showed that there was a association between, having spinal stenosis and RFA outcomes, not because you want to treat these people, but because they have real pathology. The same risk factors. People don't just get facet degeneration in isolation.
Excellent. I'd like to move the discussion a little bit now into section 3, where we're going to talk about the overlap of procedures. And Dr. Barnhill, you are up.
But Doctor, I haven't answered question 14 yet. The criteria.
I'm sorry. Go. I'm sorry, Dr. Tracy.
Okay, so it is my opinion that studies are designed to exclude patients when it is thought that they would affect the outcome of the study or interfere with the outcome of the study. So in my opinion, these evidence-based papers are not real life, and it's difficult to use the evidence in the literature to exclude patients. So when you were asking these questions, I was thinking, are you trying to exclude people with coagulopathies? If so, the ACIP guidelines published states that they would continue Coumadin or anticoagulation therapy. You have that draft on page 2009, as long as the INR wasn't greater than 3. I believe that, and the literature would support taking people off their induced anticoagulation therapy is more risky than doing a facet block, especially that it's outside the neuraxis, and you know, using pressure and pressure dressing. So I would not exclude people with induced coagulopathy as 1 or 2 diagnostic blocks, and then a radiofrequency ablation would mean weeks of taking them off their coagulation medications, and that would be very risky. Some of the papers in the bibliography excluded English speaking. Well, certainly we wouldn't exclude a person from getting a diagnostic facet block or any facet injection because they don't speak English. They cited inability to complete the forms. They did cite radiculopathy, and I think Dr. Cohen and myself had made the case for multifactorial back pain, with facet joint being one of the etiologies. They excluded rheumatoid arthritis, which I would not agree to because these people have pain in many different joints, including the facet joints. They excluded psychological problems, which I would not include. Just because you're mentally ill doesn't mean you shouldn't get treatment. A history of surgery. These people can often develop facet distraction from changes in the architecture of the spine secondary to the surgery, and can do very well with facet injections and get that 50%. And also they excluded lumbar spinal stenosis and herniated nucleus pulposus, and I think Dr. Manchin made a strong argument for patient selection criteria, and that's what we would use in that case. So the only reason I could see that you wouldn't want to move forward with these types of injections, I do, by the way, think that metastatic prostate cancer responds very favorably to steroid injections and facet joint injections if there's those nerves are involved. So the only reason I can think of to avoid or exclude a patient would be if you wanted to avoid radiation, so pregnancy. If you had an acute myelopathy, which should be evaluated immediately by a spine surgeon, but we see patients that have foot drop for years, so that wouldn't be a contraindication or an exclusion. And infection, active infection would be an exclusion. So that would be my recommendation. If you'd like me to clarify, I can.
So this is Dr. Schwachman. I agree with Dr. Tracy. This is what I was trying to say, is that just excluding people because they've had some other disease, including like diabetic neuropathy, which I cited before, or she cited rheumatoid arthritis or something like this, is just incomprehensible. There's no reason why, there's only a few reasons why you would really back off on facet joint disease. And so I think that the fact that there's others, there's no reason to tell people you can't have the at least a diagnostic procedure to see if they'll get some relief.
This is Josh Hirsch. May I make a comment?
Certainly, sir.
I made my disclosures earlier. So I think Dr. Tracy and the last speaker are highlighting something in different ways that is a pervasive problem through the LCDs, which is that in an effort to be evidence-based, which is completely appropriate, exclusion and inclusion are often matched to trials, which in no way are actually meant to mimic the real-world way patients present. And I mean, I could cite multiple examples beyond facet joints where that's true. I don't know the right solution as Medicare tries to move towards greater evidentiary basis, but I do think it reflects a real problem. And there's feedback on a recent coverage decision where matching the real world to what are exclusion inclusion to make a clean trial has led to, I think, some real problems for patients. So it's just something I think with this many, this level of talent of CMDs on the call to think about as we go forward.
I appreciate that.
I would build on that actually to say that, you know, when you exclude patients from treatment, and I think Dr. Cohen touched a little bit on it, they're going to seek another treatment or another one. They're going to go someplace else and they're going to get another treatment. That might not be the best treatment or the treatment that's the safest or best. So he alluded to opioids. It was alluded to surgery. There will be some other place that they will go.
In the interest of time, I'm going to move to Dr. Barnhill to answer section 3, question 1, regarding other types of interventions at the same time as a facet injection.
Thank you. This question they're asking, can you do an injection of intra-articular or medial branch close, an additional injection close to the location, or do it in conjunction? So the question asks, what is your level of confidence based on clinical literature to support that the following procedures should not be used in the same or close location and in conjunction with the Z-joint injection procedure to reduce false positive diagnosis and or false positive error rates in Medicare beneficiaries with spinal pain and facet joint origin? It's very difficult to locate any literature attesting to the sensitivity or specificity of facet injections, either intra-articular medial branch, that were concurrently administered with any other procedure. Prospective studies would have difficulty assessing efficacy in combined procedures due to subject variability in normal and abnormal pain pathology, placebo response, and other confounding variables. I did find in the CMS LCD, an older one, that states, and I quote, Medicare does not expect that an epidural block or sympathetic block would be provided to a patient on the same day. Multiple blocks on the same day could lead to improper or lack of diagnosis. Exception. Coverage would be extended for only one type of procedure during one-day session of treatment, unless the patient has discontinued anticoagulant therapy for the purpose of an interventional pain management. I scored these all a 1 due to the lack of evidence that I could find.
Anybody else?
So this is DJ Kennedy. I just have a clarification question, meaning the question says, should the procedures not be used in close location, the level of confidence that they should not be used. So if we score a 1 versus a 5 in answering that question, to me, in reading that, a level 5 is I have high confidence that they should not be used, and a level 1 is I have a low confidence that they should not be used. Is that correct?
So yeah, the question for explanation is that, as Dr. Barnhill, I believe, scored it, should the procedure not be used? And so if you believe they should not be used together, that would be a low score as opposed to a high score.
This is Dr. Schwachman. Thank comment on that. I think you have two situations going. If what you're doing is a study, then you want to isolate exactly what your point of the study is and eliminate as many variables as possible. If you're treating people in the real world, all you want to do is you want to eliminate the pain and restore function. You don't care if it was the epidural that did it, or if it was the facet joint block that did it, because for one thing, the goal is not to produce a beautiful study, it's to get the person well and functional. And that's the goal. And
but let me press you on that one. Let me press on that one just a bit. So your position is that you should do them. Is that correct? Together?
You should do them if you have inclusive criteria for doing them. For example,
and what is the literature that supports that?
For example, let me point out to you that one of the descriptions of facet joint pain includes pain that's low back pain that radiates into the lower extremity, but only along the posterior aspect and no further usually than the knee. That can just as easily be a radiculopathy as the facet joint pain. So what are you going to do? Do the facet joint as a diagnostic thing, and then send the patient home and then bring them back. And there's a cost factor in that. There's a risk factor in them coming in the operating room. And now you're going to bring them back, and now you're going to do the epidural. Why not do them both together, and the patient gets better? You don't know which is which, but hey, the guy's better. He's functional. He doesn't have pain.
Well, yeah, but then if you don't know which, then every single time they have pain, they're going to end up getting multiple procedures they may not need.
It's better than going back to the operating room and taking that risk.
I question, the hard part is I know of very limited literature that combines those. And part of that is it was pointed out, and it was pointed out very appropriately, the studies are designed to be clean, right? That they are looking at individual patient populations. Yet when we take the work of Mike DePalma, for instance, the number of people that he's able to identify a single pain generator is actually fairly substantial. The number of people with multiple overriding pain generators that require all kinds of different procedures all at the same time was very low in his group. And I recognize groups are different across the spectrum, but the number of people that need multiple procedures at the same time for me based on after an examination of history, physical, and review of imaging in my practice is very limited. And we do outcome studies on all our patients with, keeping track of them via independent registry. And we have literature, our outcomes are similar to what's reported in literature. So, I think that it is a little bit tricky to do some of those things.
Well, you've pointed to studies. And I agree with you. If you're doing a study, you want to limit it and identify where the pain generator is no matter what, and you want to have a clean study. In the real world, you're taking people back into an operating room. There's a risk there. There's an excessive cost there. And how much harm do you do the other way around? And that's in the real world. In the study, I agree with you. And that was pointed out by one of the...
I'll agree. I completely agree. There is a difference between clinical and real world. I do practice in a real world and very rarely do multiple procedures at the same time and, have good outcomes with my patients, which I monitor. And the question asked specifically, what is the clinical literature to support the following procedures?
I'm concerned that Medicare will then stop us from, in the real world, doing more than one procedure on the patient. And that's what I'm worried about, is they'll take the idea of what a study is and graft it into the real world, and then we're precluded from going further with it. And I think that, as Manchin pointed out before, when he talked about 3 months, that there's a situation in which you should leave it up to the physician and the patient. And there isn't a point for that. And there's a point in which you're told the patient that he's part of a study. And that's the difference. There is very little literature on it. I agree with you. And one of the previous speakers, for example, gave it a 1 for that reason.
So I'd like to move to the next question, which is number 2 with Dr. Cohen, and to address the issue of the single medial branch blocks injections versus 2.
And I think I went over the 50 versus 80%. So if you want to skip that in terms of timing. So first, let me say, that if you have a definitive procedure, which is what RFA should be, that's relatively safe and comparably expensive to the diagnostic test, then you really need to have a diagnostic test that has high sensitivity and negative predictive value so that people, don't end up getting surgeries that won't help or put on opioids. And of course, the decision also depends on the prevalence rate, i.e., pre-test probability, which DJ speaks about very, eloquently. So if you had a population with a very, very low likelihood of disease, like teenagers, then you might be able to consider 2 blocks. But here's the thing. There's not a lot of studies that you can actually calculate sensitivity and negative predictive value, which is what you want, high ones. But you can with Susan Lord's study in 1995, where they did placebo, lidocaine, and bupivacaine injections in the neck. They found a sensitivity of 54% and a negative predictive value of 68%. And Rick Derby's study in Pain Physician 2013, a retrospective study, which had a sensitivity of 55% and a negative predictive value of 53%. So in other words, this is saying that you might not need any blocks. So requiring 2 medial branch blocks is not consistent with other tests before really invasive pain procedures. So now you need to have discography before a disc replacement. You don't need to have it before, spine fusion. And I'm sure that they are accepting a paper in Pain, a big, huge, multinational, randomized trial about whether or not you need a spinal cord stimulator trial before spinal cord stimulation in foul back. Sam Moldavi is the thing, and they said you don't even need it.
So, Dr. Cohen, can you narrow that discussion down to your final opinion regarding 2 medial branch blocks?
Okay, so the literature does not support it, right? There's two randomized trials, one by us, that showed higher overall success rate and lower overall costs with less blocks than 2 blocks. And there's another study by Zach McCormick in the knee that there was no difference between 0 blocks or 1 block. And the whole point of doing 2 blocks is to reduce the false positive rate. But the more blocks you do, it's inevitable that you will have false negatives. And the false negative rate is really important, right? Because these people aren't going to get treatment. And, Rick Derby is the only guy with good information, and he found that there's a false negative rate of 47% when he put the cutoff at 50% or the cutoff at 70%. And out of those people, 8 of them had radio frequency and 6 of them got better. So in other words, 2 blocks, here's the bottom line. You will have an overall higher percentage of radio frequency denervation success rate. It will be higher. But overall, because you're withholding all of these, holding treatment from people who will benefit, you will have an overall lower success rate, and it will be much more costly. And almost everybody who has a second block, the second block is positive. Because, people in private practice, they're telling patients, I'm sorry, Medicare is requiring a second block, and if you don't get 50% pain relief on here, we can't do the procedure. So it's definitely, it's inconsistent with all other, prognostic procedures, 2 blocks.
I'm going to make the question a little more complicated, and I'll turn it over to Dr. Kramer to discuss that issue of actually not only getting the subsequent blocks, but how do you measure them? Dr. Kramer.
Okay, well, again, this gets back to the question that we discussed before about even therapeutic facet joint intervention. So the question is, what is your level of confidence based on the clinical literature to support subsequent therapeutic intra-articular injections or medial branch blocks at the previously injected facet joints or medial branch blocks, i.e. the same anatomic site, are effective to reduce pain and improve function? So we're getting into an issue where this is not referencing using it as a tool to determine whether a radiofrequency ablation would be appropriate, but whether we would repeat just the nerve blocks or the intra-articular injections. So again, getting back to Dr. Cohen's review, again, weak literature to support therapeutic intra-articular facet joint injections or facet joint nerve blocks. But of course, there are studies that document the benefits of these interventions. And of course, Dr. Manna Conti's review noted before supports level 2 evidence for facet joint nerve blocks for long-term improvement, and that's longer than 6 months. And he documents level 3 evidence for lumbosacral intra-articular injections for short-term improvement. So again, I think the literature, I scored it as a 3 in that regard. And then we get into some other studies. Dr. Cohen also, again, getting into the justification to repeat these interventions. The article questions, what should the cutoff be for designating a block as positive, and is there any benefit to using non-pain score outcome measures? And then the authors in the report document that the question was focused on block success to proceed with an RFA. Again, their conclusion suggesting that 50% relief combined with functional improvement documented in a pain diary would be reasonable. Dr. Manchi reported in the spine back in 2008, cervical medial branch blocks for chronic cervical facet joint pain, a randomized double-blind controlled trial with 1-year follow-up. And in his report, the results demonstrated significant pain relief greater or equal to 50%, and functional status improvement was observed at 3, 6, and 12 months in over 83% of patients. Average number of treatments was approximately 3.5 in each group over, I believe, about 15 weeks. And they concluded therapeutic cervical medial branch nerve blocks with or without steroids may provide effective management for chronic neck pain of facet joint origin. There was also a report by Dr. Dong Lee in Spine in 2018. In January, an article entitled Comparison of Intra-Articular Thoracic Facet Joint Steroid Injections and Thoracic Medial Branch Blocks for the Management of Thoracic Facet Joint Pain. These results were assessed with a numerical rating scale, concluding both intra-articular thoracic facet joint steroid injections and therapeutic medial branch neurotomy significantly relieved thoracic facet joint pain. Effects persisted for at least 6 months after the procedure. They concluded that both intra-articular thoracic facet joint steroid injections and therapeutic thoracic medial branch blocks would be useful treatment options for managing thoracic facet joint pain. We're getting into the additional questions, querying the outcome measures that would be utilized to proceed with additional facet joint intra-articular injections or medial branch blocks, and what objective documentation would be required. In 3A, paragraph references a minimum of 80% sustained relief for the first and second medial branch block, duration of relief being consistent with the agent used. Dr. Cohen and the consensus guidelines, I think it's been stated several times, but in the absence of any reliable treatment options for patients who obtain greater than or equal to 50%, but less than 80% relief, at least in this report, the committee opted to maximize access to care. So again, I really feel the 50% mark would be more appropriate, and that 80% would set the bar too high. And I don't, at least in my review, I feel that the literature does not support a minimum of 80% sustained relief of the first or second medial branch block. And then in 3B, I thought the literature supported a minimum of at least 50% sustained improvement in pain and in the ability to perform previously painful movements and activities of daily living for at least 3 months. So I thought I gave that a score of 4 in the question 3B, the score of 3 in the for question 3A.
Thank you, Mike. You did a very good job with that focused response. I appreciate that. If I could turn to Dr. Manciotti, because there's the next question. Question 4 is also very complex and has multiple nuances to it. So Dr. Manciotti, please.
Thank you. Again, this is Dr. Manna Conti. I just want to apologize for everyone, for Dr. Cohen, for him insulting all the private practitioners. Economy is the only thing we are involved with. In reference to the evidence, it is still coming, and we will see in a few days. My first question is, diagnostic injection should be a minimum of 28 days apart. This probably will elicit, again, significant controversy and discussion. Some say that if a patient is getting 45 minutes or 1 hour of relief, then they can go ahead and have a second block the same day and have a radio frequency next day. There are other treatments for people who cannot have radio frequency. And again, 30 to 40% of the patients do not respond to radio frequency and they want another treatment. Generally, we go with facet joint nerve blocks, but if they fail, if they don't respond to these things, they do have other things going towards epidural injections, for example. There are multiple studies. So in my opinion, 28 days apart is reasonable. If we take the chronic pain model, if you take the acute pain model with expected relief of 45 minutes to 2 hours or less than 7 hours, less than 24 hours, as Bogdoc has recommended, it may not be appropriate. Right now it says 2 weeks, I believe, and this is going to the 4 weeks. And
I agree. The question is going to be on chronic pain models. Thank you.
So that's correct. So that's what. There is a significant improvement with the pain and function. It does not have to be 80%. 80% relief lasts for several hours or a day or so. We have shown that it can last for 2 months a second time, 6 to 12 days the first time with the 80%. But long-lasting relief is about 13 to 16 weeks. Again, I already discussed about this chronic pain model and extended relief. And I have given you the guidelines, the draft version, but it has table 16 and 17. It shows that relief is much longer than what has been described. So that answer is yes for that. The next question is, therapeutic injections should be a minimum of 3 months apart. That is accurate. Some of the policies, because of the issues related to LCDs, which were revised. In the past, we had a single, nice, beautiful LCD, but everything was changed for unknown reasons. Now, we have conflicting information, like some of the LCDs say that there should be 3 months of relief, but they can have 5 injections in a year. That is bizarre, internally inconsistent, but 3 months is fine. And like CGS says, it is in therapeutic phase 4 per year. Actually, originally this all started with NGS when it covered Kentucky, which was administered federal. Then third question is, interventional procedures at different regions should be performed at a minimum of 2 weeks apart. I do not believe so. There is not any evidence to do so. This will only increase the discomfort for the patient and increases the utilization. We just did a study, and it is in publication. It showed that staged episodes of radiofrequency neurotomy were performed in almost 24% of the patients, and more than 2 episodes of radiofrequency per year were performed in 7% of the patients in lumbar spine. When you went to the cervical spine, it was 20% and 5%. So this increases the utilization patterns, causes significant inconvenience, and especially in post-COVID era, we are looking at PPE, so we are using it twice. So we always believed that, we have written always in the guidelines that we should try to do them in one setting to the best of our ability. If not, then we can go to a different level. Like Tracy brought that up, Dr. Tracy, that patient is an antithrombotic. Some people do stop them. In those cases, it really increases their risk. So we should be able to perform the procedures in less than 2 weeks, and especially at the same setting. If not 2 weeks, 4 weeks, it doesn't matter. In the next question, in the treatment phase, interventional procedures should be repeated only if medically necessary and not to exceed 4 times in 1 year. That is accurate. That is what CGS says, but others say 5. The next one is for facet neurolysis frequency would be only of medically necessary at minimum of 6 months apart. That is accurate too. I agree with that. Number 5. Oh, that is not my question. Okay, thank you.
Excellent. Thank you, sir. Dr. Kennedy, I'm going to have you go to the next question. And for the sake of time, I would like the additional answers to be focused as best you can. Dr. Kennedy?
Perfect. So what is the confidence in the clinical literature support facet injections or medial branch blocks being allowed for 3 spinal levels per anatomic regions, diagnostic or therapeutic, in 1 session? So the published literature shows the 2 most common conditions causing facet-mediated pain are osteoarthritis for the lumbar spine and whiplash for the cervical. It really would not be consistent with our knowledge of either of these disease processes to suggest that they could only affect 1 or 2 levels. However, there also is prevalence data that demonstrate 3 levels should not be the norm or routine. In the lumbar spine, the highest prevalence for facet is the L4-5 level, followed very closely by the L5-S1 level. Combined, these 2 joints comprise around 80% of the overall prevalence for lumbar facet-mediated pain. Given they are generally indistinguishable based on history or physical exam, it is reasonable to routinely target both of these given the high prevalence, especially for procedures targeting medial branches which have overlapping innervation. However, in the lumbar spine, all the other levels combined have less than 20% prevalence, and there is no strong data on the prevalence of people with 3 or more level disease. So the need for a 3-level procedure should be well under 20% in the lumbar spine. In patients with whiplash and neck pain or headache, the C2-3 facet joint was found to have a prevalence of around 50%. For whiplash patients with neck pain below C2-3, the overall prevalence of facets was combined around 60%, the highest prevalence being 5-6 and 6-7 joints. These studies have not been replicated for osteoarthritis, which is the patient population we're talking about, but cadaveric dissection studies have shown osteoarthritis to be more common in the mid-cervical regions between C3 and C5. Regardless, when compared to the lumbar spine, the cervical spine does have a more distinct pain referral patterns, as well as a higher reliability in the palpatory exam, which should help facilitate picking a particular level more easily than the lumbar spine. It is very unclear how often 3-level disease occurs in the cervical spine, and we do not have strong studies showing the outcomes from 3-level procedures in the cervical spine.
Thank you, Dr. Kennedy. We can move to question 6, and Dr. Manchin, please address that.
Thank you, sir. Question is, what is your level of confidence on a scale of 1 to 5? The clinical literature supports that when subsequent thermal medial branch radiofrequency neurotomies at the same anatomic site are considered medically reasonable and necessary if the facet joint denervation has objective documentation to show minimum of 80% from diagnostic injections with the duration of relief being consistent with agent used, or objective documentation to show a minimum of at least 50% sustained improvement in pain and in the ability to perform previously painful movements and ADLs for the last 6 months. This is, you may be able to change it to the same anatomic region rather than, well, it does say same anatomic site. So it is also says the painful movements as I was talking before. So it is already in the policy. Now, there is good evidence for repeating radiofrequency neurotomy. There are multiple articles showing that repeat radiofrequency neurotomy does work. The level of evidence for lumbar spine is level 2 with moderate strength recommendation for ablation with 11 relevant randomized controlled trials with 2 negative studies and 4 studies showing long-term improvement. When we come to cervical spine, level of evidence is again 2 with moderate strength of recommendation with inclusion of only 1 randomized controlled trial. There is only 1 randomized controlled trial. That was also published a long time ago. But there are 2 observational studies showing improvement, and that 1 randomized controlled trial had only 12 patients in each group. The level of evidence is 3 with weak to moderate strength of recommendation for thoracic radiofrequency ablation with inclusion of 1 relevant randomized controlled trial and 3 observational studies. The reason why we gave them a higher evidence is strength of recommendation is because it is a evolving subject and there is emerging evidence on that. The question under there is, does the literature support repeating imaging for repeat thermal medial branch radiofrequency neurotomies? Answer is no, level of evidence is only 1. Does the literature support a requirement to have repeat diagnostic injections prior to repeating thermal medial branch radiofrequency neurotomies? Answer is no, level of evidence is only 1. And I'm done there. Thank you.
Thank you, sir. That was very well done. Thank you. Dr. Moss, could you go on to number 7, please?
Yes, question 7. Are there any evidence-based strategies to improve the safety and reduce complications associated with facet joint injections and procedures? Answer, yes. Facet interventions inclusive of medial branch blocks, intra-articular injections, and RF denervation are safe procedures with very limited reported complications. The consensus guidelines on facet interventions by Cohen and colleagues divide adverse events on lumbar facet procedures into vascular penetration and injury, procedure-related pain or dysesthesias, injury to adjacent structures, consequences of muscle denervation, and finally impact on implanted electrical devices. Each of these categories has its own body of literature describing adverse event rates and strategies for minimization, which are nicely addressed in Dr. Cohen's guidelines. The very specific procedure-related methodologies to minimize adverse events for facet interventions also described in the practice guidelines of the International Spine Intervention Society, now SIS. If one wishes to assess the effectiveness of these procedural guidelines, this require large cohort studies where those guidelines be followed, and such studies do exist. A large multi-institutional study by Carr and colleagues, which was performed at Mayo, Northwestern, and Penn, on over 6,100 facet interventions where SIS procedural guidelines utilized, found no major adverse events to be inclusive of neurologic. The most common minor adverse events in those procedures were simply vasovagal reactions, 1% for facet injections, 2.7% for medial branch blocks, 3.4% for RF procedures. All the minor adverse events were orders of magnitude. Answer, yes.
Thank you, sir. Dr. Simopoulos, question 8. Dr. Simopoulos, are you there? I will come back to 8 and move to, oh, are you there, Dr. Simopoulos?
If you want to, I don't know, I'm not seeing him. So, well, we can come back or I can answer that question. This is Dr. Manchin.
Let's, thank you, sir. You're very helpful and I appreciate that. And so we'll move to Dr. Schwarzman.
Yeah. The question number 9 is, should these facet joint interventions be performed under fluoroscopy or CT guidance? And my answer is 5. There was a study a number of years ago in which the epidurals were done blindly and then checked up, and the failure rate of actually appropriately placing the needle, I believe in that study years ago, was the failure rate was as high as 25%. Originally, the epidurals, I believe, were done under caudal, but as it moved to anesthesiologists, they couldn't read the x-ray, and they needed an endpoint. And intervertebral has an endpoint, the loss of resistance. Now, you coming over to facet joint, again, there is no endpoint. And so you have to be able to use an x-ray or a CT scan to see where you're going. And then you're able to do it without the endpoint because you can see what you're doing. So I believe that it has to be done. It's mandatory that it be done under vision, and that's based on the history. The study that was done years ago, a 25% failure rate in appropriately placing the needle when done blindly, in spite of an endpoint. So I believe that the answer to that is a number 5.
Thank you, sir. Dr. Tracy, would you like to please address number 10 about ultrasound guidance? Dr. Tracy?
Oh, I was on mute. I didn't realize it. So the question in front of you is, what is your confidence that there is sufficient clinical literature to support facet joint interventions, diagnostic or therapeutic, can be performed under ultrasound guidance? So I gave that a 1. In all the papers in your bibliography, 1 through 20, they all used fluoroscopic guidance. Dr. Manchin in paper number 12 mentioned a study done on ultrasound guidance that was mostly geared at placement of blind versus ultrasound or fluoroscopy versus ultrasound. There's no thoughtful commentary in any of these papers on ultrasound. However, the paper that was referenced previously, the consensus paper in the international group, they had 2 pages of thoughtful commentary on the use of ultrasound. And I'll read you the summary. The disadvantage of using ultrasound for lumbar spine injections include limited visualization of the field. In other words, we can't see as many segments as we can with fluoroscopy, lengthy learning curve, and potential for inadvertent vascular uptake, which can be reliably detected using real-time contrast injection or digital subtraction angiography. Furthermore, leader visualization is impaired by body habitus and depth of the target. I also spoke to Dr. Andrea Trescott, who edited a book on peripheral nerve entrapment using ultrasound guidance for nerve injections, published in 2016 by Springer, and using ultrasound experts all over the world, concluding that facet injections would not be favorably performed under ultrasound. Because there's limited evidence in the literature, I also spoke to fellowship-trained interventionalists. Dr. Rashad Julia is a fellowship-trained in ultrasound, and he does his blocks under fluoroscopy. So that one gets a 1 for me.
Thank you. Dr. Barnhill, would you like to address question number 11?
Yes. What is your confidence based on the clinical literature to support the use of a facet joint cyst rupture to provide facet-mediated pain relief? I found quite a bit of literature on this one, so I gave it a score of 4. Here's my rationale. Although various interventional strategies for facet joint cysts have been suggested, Most techniques involve disruption of the cyst itself via access. It can either be trans-facet joint or modified epidural, aspiration and or distension, and injection with saline, contrast, corticosteroid, local anesthetic, or any combination. And this is all done via image guidance. And this is from the work of Booty and Savage, as well as Shang and others in 2014. In 2018, Janssen, Onk, and Schwab found the prevalence of facets to be 6.5%. Of those, 46% were incidental and 54% were symptomatic. Facet cyst presence was associated with increasing age, and symptomatic cysts were found to be larger and more anterior in the spinal canal. This is based on the work of Janssen in 18. Facet joint cysts may be a marker of spinal segmental instability and may be predictive of the need for surgical fusion in symptomatic patients. That was said by Ramde in 19. MRI can assist with differentiating thick-walled cysts with heterogeneous signal that appear to be more difficult to treat. As an alternative to surgical intervention, a 2014 meta-analysis to evaluate the success rate of percutaneous resolution of lumbar facet joint cyst revealed satisfactory results, as high as 55.8% of cases. This was Shang in 2014. In a more recent systematic review, Campbell, Mobbs, and Rao found in 2017 the rate of symptom resolution for percutaneous approaches to be lower than 58% compared to surgical intervention, which was 90%. Of course, this must be weighed against the relative risks of each therapy. Some authors have reported superior results with CT guidance versus fluoroscopy, and CT superiority after unsatisfactory results with fluoroscopy. This is work on, once again, Booty, Chazen, Singh, and Schweitzer in 2018. In 44 patients who underwent CT-guided synovial cyst rupture and a steroid injection, Hyder reported that technical success rate of 84%, an improvement in measures of their pain, their function, and analgesic medication use over a one-year follow-up. However, successful rupture did not present subsequent surgery. More recently, Shaw in 2018 reported a high rate of relief with facet cyst aspiration and fenestration procedure resulting in complete or partial symptom relief in 86% of patients. The study had 64 in it. During a mean follow-up period of 49 months, 56% of patients reported persistent satisfactory relief and 44% underwent surgical treatment. These results are comparable to the findings of Hong in 17, who reported on long-term outcomes in patients who underwent CT or fluoroscopy-guided facet cyst rupture. Over a mean follow-up time of 44 months, 12% of patients underwent repeat cyst rupture, and 46% eventually underwent surgery, whereas the majority of patients, an estimated 55%, experienced symptomatic relief and did not undergo surgery. There are no studies directly comparing imaging modalities, but relative consistency in outcome reporting. In a prospective cohort study by Lutz in 18, 35 subjects underwent percutaneous fluoroscopy-guided facet cyst disruption in the treatment of low back and radicular pain secondary to cyst presence. Subjects reported clinically and statistically improvements in pain. They used the NRS, best, and worst scales to measure, as well as they measured function with the ODI. Interestingly, one-year follow-up, 87% of the subjects reported continued satisfaction with their initial procedure. However, 40% went on to have surgical correction. Although some authors have posited facet cyst interventions reduce surgical need, factors related to long-term success have not been explored. A proposed grading system by the Neurospine Surgery Research Group grading score may be predictive of response to surgical intervention versus cyst rupture. There remains a need for further study to better define patients' response to facet interventions as well as optimal procedure technique. Therefore, a review of current literature suggests facet joint cyst rupture is a safe and reasonable approach in providing relief of pain associated with the cyst presence. Conclusion.
Thank you, Dr. Barnhill. Dr. Cohen, you get the last question and get to out in a 3-minute period of time.
Yeah, so I would just refer to something that we had, a table in an article. So 2007 December anesthesia analgesics, the cover article. It's on, the ability of diagnostic blocks to predict operative results. So I mean, I would say that I have no confidence at all. So it's less than 1, in this. So basically, if you fuse the spine, so if you do any kind of fusion or arthrodesis, you have less motion and less stress on the facet joints. That's work by like Partop Kalsar and Iannuzzi. But when they've looked at studies, there's a bunch of them in that table that I cited. So Jackson in 1992, Esses and Morrow in 1993, an earlier one by Esses. Fusion doesn't work for facet joint pain. And in fact, as you know, you end up getting adjacent segment disease after fusion. So the rationale for these implants is that, oh, yes, it actually work for facet joint pain, but it's just so painful you can do something minimally invasive. The problem with these things is you're not actually, rendering that segment motionless, and they fall out all the time. It's very hard to put them in. And there's just no data to support it. So you have to go by these older studies from the 1990s, and they do not support, fusion.
Thank you, Dr. Cohen. I'm going to turn the time back over to Dr. Lovelace and for the concluding remarks and/or statements she needs to make.
Thank you, everybody, for the tremendous education and covering this large amount of material in such a thorough and educational way. We do ask our panelists to also submit their feedback in writing, and I remind our jurisdictional CAC members to submit their comments to their local MACs in writing with their voting within the next 2 weeks. They will also need to complete their conflict of interest form. The audio and transcript will be posted to each of the MAC's website in the next 3 to 4 weeks. I know some need to drop off because we are over time, but I do want to give an opportunity if any of our CMDs have additional questions for our panelists while they're on the line. I have reviewed the questions and from our audience, and those appear to have been answered throughout the process. Are there any additional questions from our CMDs?
This is Dr. Tracy.
Yes.
May I speak? Yes, I would just like to say that oftentimes when developing policy indications and limitations, how you word, use an and or an or a thir, a the, it has implications, and we're left here to interpret it. So I would just like the directors to know, as we're all sitting here, to take a very specific approach to the development of the language and how it's going to be interpreted, and maybe even use some of us to do that, because you can see in this session, many of us didn't even understand the question. So development is really important. Thank you.
Thank you.
And thank you for
Kennedy. Your feedback.
I'll echo the same thing, that the questions were challenging to interpret exactly what was being asked, which I know seems like a fundamental thing, but when you have a panel of experts that clearly were having this level of difficulty, there needs to be some more clarity and thought in terms of the specifics of the question, and I'm happy to help with that if that's helpful.
Yes, thank you. That's good feedback for us. And then we also, once a draft of the policy is made, that draft will be posted publicly. It will go to the jurisdictional open meetings, and there will be a response to comment time, at which point we can also make sure we address any any wording confusion in it, as well as working collaboratively in the development.
So I heard they were keeping a
Is there
file.
any? And we also will ask for our panelists to turn in their comments and to make sure to complete their voting. We do ask that voting to be completed today if possible. Any other questions or comments from our CMDs?
Thank you for all the hard work that you've done to make this work.
Thank you, everybody.
Yeah, it was really my pleasure to be on the call with everyone. Thanks for putting this together. Thanks for including me. What a amazing group.
And thank you, each of you, for your time. I know you're all busy and your time is valuable. So thank you for being part of this meeting, and we'll look forward to continuing to work with you as we move forward with the development of this policy. Thank you, everyone. Have a great evening.
Thank you.
Thank you. You too.
Thanks, you too.